Good morning. Wishing a very good morning to all the delegates, faculty, postgraduates, undergraduates, and all the participants of this continuing medical education program.
It gives us immense pleasure to invite you all to Dr. C.R. Bidri Memorial State Level Continuing Medical Education Program on Oncology.
We request you all to be seated as the program is about to commence. We seek your cooperation by keeping your mobile phones in silent mode or switched off. Thank you. I request you all participants to occupy your seats once again.
I request Dr. Y.M. Jairaj, Honorable Pro-Chancellor, Chief Guest of today's function, Dr. R.S. Mudol, Honorable Vice-Chancellor, who is presiding today's CME program, Dr. Arun Inamdar, Pro-Vice-Chancellor, Dr. R.V. Kulkarni, Registrar, Dr. Anand Patil, Vice Principal Clinical, Dr. S.N. Bentur, Head of the Department of Medicine, Dr. H.D. Lata Devi, Chairman of Scientific, Academic and Research Society, Dr. R.C. Bidri, the convener of today's program, and Mrs. Asha Patil, as a special representative of Dr. C.R. Bidri family, to kindly occupy their seats on the dais.
Madam and Sir, we have 4 distinguished guest faculty as part of this CME program. We request you to please be seated. Once again, we welcome you all to the CME program on this pleasant morning. Dr. Anand Patil, Vice Principal, Shri B.M. Patil Medical College, will welcome the gathering. Sir, please.
Good morning, everyone. It gives me an immense pleasure to welcome you all for this annual Dr. C.R. Bidri Memorial State Level Oncology CME, which is into the 11th year. Enhancing our knowledge, and which is jointly organized by Department of Medicine and SARS Society of our Medical College. As all of us are aware, late Dr. C.R. Bidri was a wonderful human being and a great clinician and a good administrator, which we saw as a principal and dean of this medical college. In spite of his physical disability, Sir served the society, and he was one of the greatest pediatrician bar physician of this part of Karnataka. We should all look up to Sir as role model, and I would like to consider him as the brightest shining star who taught us you can believe in only one life lived. He believed in only one life lived, and others is a life. This is what he taught, and he always lived up to the best of his abilities and served the society at large in spite of his physical disability. And I'm fortunate that I was one of his students, and I'm also fortunate that Dr. Raju Bidri sir is also my teacher. I'm doubly honored that both of them taught me, and I feel proud that what I am today is because of their blessings and their advice. I take this opportunity to welcome Honorable Pro Vice Chancellor Dr. Y.M. Jairaj sir, who is always supportive of such activities, academic activities. President of today's function, our Honorable Vice Chancellor Dr. R.S. Mudol sir. Pro Vice Chancellor Dr. Arun Inamdar. Registrar Dr. Raghavendra Kulkarni. Dean Dr. Arvind Patil sir. Convener of this CME Dr. R.C. Bidri, who is ever enthusiastic and who is instrumental in arranging these annual CMEs, which is enhancing our knowledge and our skills to some extent. R.M. Honutgi, who is examiner, who is organizing secretary. Dr. Bentur sir, head of the Department of Medicine. Lata Dev Madam, former head of Department of ENT and presently chairperson of SIRS. And a special invitation to our Asha M. Patil Madam, who is always there to help us, support you, and who is, all of you know about Ashaka. I think I should give a big round of applause to her for your support for this medical college and conducting camps and helping us and all the downtrodden and the society. I'd like to invite our guest faculty for today's CME who have come from SCG Bangalore. Dr. Lohit, who is a consultant radiation oncologist. Dr. Abhilasha Narayan, gynec oncologist. Dr. Prabhu Nesargikar, surgical gastroenterologist and bariatric surgeon. Dr. Nataraj, hemato-oncologist. I also take this opportunity to welcome you all my fellow colleagues, heads of the departments, staff members, postgraduates, interns, and students, and delegates who have come from various parts of Vijayapura, Al-Amin Medical College, Ayurved Medical College, and all the faculty who have gathered here to be part of this annual CME. I request you to get enriched by the expertise and knowledge of our guest faculty. Once again, I welcome you all. Let us be part of this CME, and I request your cooperation in future also. Thank you.
Thank you, sir. Late Dr. C.R. Bidri was a luminary in the field of medicine, social and community work, was qualified in various specialties of medicine, including MD General Medicine, DCH in Pediatrics and diplomas in dermatology, and decided to serve the people of this backward district of North Karnataka by settling in Vijayapura. He was awarded the Best President Award of Rotary Club Vijayapura and IMA Vijayapura, where he worked actively in social and community services.
Separation is a wound that no one can heal, but remembrance is a gift that no one can steal. In remembrance of Dr. C.R. Bidri and his contribution to the society, community, and medical services at large, the dignitaries on the dais, the guest faculty, and the senior faculty will pay homage in an orderly manner by paying floral tributes to the portrait of late Dr. C.R. Bidri, in whose memory the CME is being conducted.
तू बुद्धि दे तू तेज दे नव चेतना विश्वास दे तू बुद्धि दे तू तेज दे नव चेतना विश्वास दे जे सत्य सुंदर सर्वथा हा जन्म त्याचा ध्यास दे तू बुद्धि दे तू तेज दे नव चेतना विश्वास दे हरवले आभाळ ज्यांचे होतयांचा सोबती सापडे ना वाट ज्यांना होतयांचा सारथी हरवले आभाळ ज्यांचे होतयांचा सोबती सापडे ना वाट ज्यांना होतयांचा सारथी साधना करीती तुझी जे नित्य तव सहवास दे जे सत्य सुंदर सर्वथा हा जन्म त्याचा ध्यास दे तू बुद्धि दे तू तेज दे नव चेतना विश्वास दे जाणवाया दुर्बलांचे दुःख आणि वेदना तेवत्या राहो सदा रंध्रातुनी संवेदना धमन्यातल्या रुधिरासया खलभेदण्याची आस दे सामर्थ्य या शब्दांचे जे सत्य सुंदर सर्वथा हा जन्म त्याचा ध्यास दे तू बुद्धी दे तू तेज दे नवचेतना विश्वास दे विश्वास दे विश्वास दे.
Now that the paying of homage is over, we request the dignitaries to kindly be seated. The inaugural function is divided into two parts. One is the formal part of inauguration on behalf of university and the institution, which will be followed by felicitation for the guest faculty, through which the inauguration function will finally conclude. The formal inauguration of continuing medical education program will begin by symbolic watering of the plant.
Hello.
Now, I request Dr. Shailaja Patil, Professor of Community Medicine, to present bouquet to Honorable Pro-Chancellor Dr. Y.M. Jairaj. Dr. R.S. Mudol, Honorable Vice Chancellor, shall receive. Dr. R.S. Mudol, Honorable Vice Chancellor, shall receive a bouquet from Dr. Anand Ninbal, Head of Dentistry. Dr. Sureka Hipparagi, Head of Department of Pathology, is requested to present bouquet to Mrs. Asha Patil, who is representative of Dr. C.R. Bidri family. Our Pro Vice Chancellor, Dr. Arun Inamdar, will receive a bouquet from Dr. Uday Kumar Nucci, Head of Department of Forensic Medicine. Dr. R.V. Kulkarni, Registrar, will be presented with a bouquet by Dr. M.R. Gudidini, Professor of Community Medicine. Dr. Sridhar Patil is requested to present bouquet to the Vice Principal, Dr. Anand Patil. We request Dr. S.N. Bentur, Head of Department of Medicine, to receive a bouquet from Dr. Rekha Biradar, Professor of Community Medicine. Dr. H.T. Lata Devi, Chairman of Scientific and Academic Research Society, will be presented a bouquet from Dr. Shravan Kumar. Dr. Vijay Katti, Professor of Anesthesia, is requested to present a bouquet to Dr. R.C. Bidri, convener of today's program.
Dr. Arvind Patil, Principal and Dean Faculty of Medicine, will be presented bouquet by Dr. M.R. Gudidini. Dr. B.C. Uppin, Medical Superintendent, will be presented bouquet by Dr. Vishwanath Jalavadi, Department of Medicine. Dr. Vijay Kumar Kalyana Bugol, Medical Director of Super Speciality Hospital, will be presented bouquet by Dr. Venkatraman Joshi. Dr. Sumangala Patil, Vice Principal, Pre and Para Clinical, will be presented bouquet by Dr. Anuja M.K.
Our chief guest of the day, Dr. Y.M. Jairaj, Honorable Pro-Chancellor, BLDE deemed to be university, who is serving as both mentor and guiding force for the university and other institutions, and being the representative of our Honorable Chancellor, Dr. M.B. Patil, will now address the gathering.
My colleagues and dignitaries on the dais, special invitee Dr. Asha Tai ma'am, convener of the CME, Dr. R.C. Bidri sir, resource persons who have come all the way from Bangalore, who will be enlightening us on the topic of today's CME, and my dear colleagues, my dear students, invitees and friends. I'm extremely happy to be amidst you today to inaugurate this state level continuing and medical education program arranged in the honor of Dr. C.R. Bidri. This particular program has two significances and milestones. The first milestone is this particular CME's topic is a burning topic and a topic of 21st century, namely oncology. As students of medical science, we are aware that 19th century was a dogma wherein there was a question mark as to what causes diseases. And we all believed that it is because of the curse of the god or the goddesses which ultimately brought us. And we always believed in this karma philosophy that it is because of the Purva Janma karma that we are suffering from the diseases and ailments. But then came the dawn of 20th century where we were open to the causes of the diseases and we were able to understand the cause of the diseases, particularly the communicable diseases and also the diseases because of the malnutrition and the growth and developmental disorders. And when we are about to say that we have conquered the medical field with the era of antibiotics, diagnostics, as well as curation and therapeutics, WHO in 2014 said that the role of the doctor is not just to cure the disease, but they gave a list of the mandatory things that a doctor has to follow. The first and the foremost thing is the promotion of the health. So we should give importance to the promotion of the health first. How exactly what health is, the physical and the mental health, and the coordination of the mental and the physical health. And at the same time, how exactly we should encourage people, educate people, enlighten people about the importance of health. Because the adage says that if wealth is lost, nothing is lost. If health is lost, something is lost. If character is lost, everything is lost. That being the case, the health and character plays a very, very important role. Only when both of them are there, other things follow. Next one is the prevention of the diseases and the disorders. The 20th century gave a lot of importance to this prevention. That is where the era of vaccinations became the order of the day in health sciences. Then the control, prevention and control and the epidemiology always became the top priority of any governments, including WHO. Then came the curation and therapeutics. That was followed by, which was totally neglected in 20th century, which is giving a lot of importance in 21st century, namely rehabilitation. When that being the case, when we are saying that we have conquered the medical dogmas, at the same time question marks, then came by the end of 20th century, the importance of cancer. Because 1/3 of the medical disorders are attributed to the cancer. First of all, none of us knew what actually cancer is. So importance was given to cancer biology, importance was given to immunology and oncology. Then we started finding out actually what causes cancer and how exactly it is going to affect the human beings. Then this particular branch of oncology, leading to medical oncology, radiation oncology, and oncosurgery, and diagnostic oncology have become primary importance in the 21st century. Because today we can say that we have conquered bacterial diseases and the epidemics and the epidemiologies, and we are yet to conquer or yet to take control of these cancer and related disorders. 21st century is now known for two important facets of health science. One is cancer, second one is the lifestyle disorders. If lifestyle disorders is affecting only one individual and we can correct him, whereas in case of cancer, if the cancer occurs, not only the individual who is suffering from the cancer suffers, but the entire family and the community suffers. That's where the importance of cancer lies. Hence, I am extremely happy today that the organizers of this CME have thought it fit enough to have a CME on a topic which is totally related, near to the heart of Dr. C.R. Bidri, namely oncology and its recent advances. So I congratulate the organizers on this particular aspect. The second aspect is that we in India, in our culture and traditions, we give a lot of importance to the homages, the sacrifice we give to the people who have sacrificed their life and their career for the cause of the society and societal service. ಕನ್ನಡದಲ್ಲಿ ಹೇಳ್ತಾರೆ, ಬೆಳಗಾಗಿ ನಾನೆದ್ದು ಯಾರ್ಯಾರ ನೆನೆಯಲ್ಲಿ ಎಳ್ಳು ಜೀರಿಗೆ ಬೆಳೆಯೋಳ ಭೂಮಿ ತಾಯ ಮತ್ತೊಮ್ಮೆ ಎದ್ದೊಂದು ಗಳಿಗೆ ನೆನೆದಾನ ಅಂತ. ಹೀಗಾಗಿ ವಿ ಸ್ಟಾರ್ಟ್ ಅವರ್ ಡೇ by remembering the Mother Earth, the solar system which is giving us the energy, and ultimately the living ecosystem. Then what else we should remember after getting up in the day? The parents who have given us birth and who have given us the life, and then the teachers who have given us the mission of life, the purpose of life, and how to lead life. And today we have arranged this particular CME in the honor of C.R. Bidri, who is a very good parent, a very good philosopher, very good teacher, very good doctor of multifaceted personality, very good athlete, at the same time a very good statesman, all rolled into one as a role model to all the youngsters who are sitting here and who are trying to pursue the career in medicine. I am extremely happy that these two important coordinations, namely the recent advances in medicine on one hand, and remembering the person who has served the society to the best of his ability despite the disabilities. That is very important. Despite the disabilities, trying to serve the society as a doctor, a physician, a pediatrician, a dermatologist, as an administrator, as head of the institution, and as a statesman, and as well as a social worker. So this is the day we should remember and ultimately pay homages to the departed soul, and at the same time say and take a pledge that we will follow the principles, the ideals, the sacrifices that particular ideal person has left us, the legacy. I'm extremely happy that the members of the family of Dr. C.R. Bidri are here today to be amidst us to ensure that we are giving a very good tribute to Dr. C.R. Bidri. And we assure you, sir, that this particular institution will give a lot of emphasis to the ideals of Dr. C.R. Bidri. On behalf of the Chancellor, let me just say that recently our Honorable Chancellor has approved and given the consent for the establishment of 200-bedded exclusive hospital and super specialty hospital for oncology and radiation oncology. And the work for it will be commencing very soon. In the existing super specialty hospital, we already have cardiology, we have got neurology and urology as well as nephrology. And recently, the principal of the medical college has given us a suggestion to enhance the super specialty services by blending gastroenterology sciences as well as neurological sciences, and we are working at it. I'm sure by the end of this particular year, we'll be having around 15 super specialty services and also initiation and initiation and foundation laying ceremony for the cancer hospital. So with these few words, on behalf of the management, let me assure you that because of the benevolent visionary, our Honorable Chancellor, Dr. M.B. Patil, sir, he always tells that patients are number one to us. The students are number two stakeholders for us. Then comes the teachers and the management. Thus, we will not leave any stone unturned to make the patients happy, to give the best of services that are available in any district headquarters and capital city. At the same time, we assure the student friends who are here that we will be giving the best education that is expected of any institution of excellence, being a A-grade institution, being an institution in NRF with 150 institutions among 1,500 universities in India. I'm sure that with the help of all of you, with the cooperation of all the staff members, and with the blessings of the benevolent management and the founding fathers, will take definitely the BLDE University and the medical college to the international standards. With these few words, I'm extremely happy to inaugurate this particular CME. Thank you very much for the opportunity.
Thank you, sir, for the motivating and uplifting speech. We all pledge to exert significant efforts towards enhancing academic research and motivating us to reach greater heights and bring laurels to the university.
As a representative of the institute and family, we request Dr. R.C. Bidri, convener of today's CME program, to address the gathering.
A very good morning to all gathered here, dignitaries of the dais, our distinguished guest faculty, delegates, invitees, and dear students. It is a very difficult task for me to describe in few minutes the personality of what my father, late Dr. C.R. Bidri, was. As Dr. Jairaj said, he was really a multifaceted personality. To the patients and their relatives, he was a semi-god, and the treatment of the patient used to begin by seeing his smile and his laughter. He used to make the patients feel better even before the actual treatment began. Second thing is, his memory was so profound. He could remember the entire family tree, not only their names, their relationship, their nicknames, and inquire after them, then take the patient's history and examine and treat the patient, which very few of us as medical practitioners do. Even many times, some of us don't even take a proper history. But he really used to spend his time, invest his smile and the enthusiasm in the patient to help cure the patient. So they used to treat him like a demigod. And even today, I still come across many of his old patients who keep saying, yes, I was treated by him for 20 years. I was treated by him for 15 years. So people still remember that. Second thing is his passion for social and community service. Despite his physical disability, he continued to be actively involved in Rotary Club activities for social welfare, as well as in IMA activities, in conducting camps, in conducting blood donation camps, and various activities. Until the last few years of his life, he, despite being a quadriparesic patient, he used to drive himself, go everywhere alone and manage working. Then comes his contribution to the family. He loved each and every one of us very much, never ever lost his temper with any of us, always laughing, and even if he wanted to convey something, it used to be in such a I do not know, probably I should say a diplomatic way, and convince that what he is saying and what he expects from us should be done by us. In short, if I have to say, he was a role model for people in society, he was a role model for people in the community, and he was a worshipful parent for all of us. Thank you.
Thank you, sir, for your inspiring and encouraging talk.
We are at the penultimate stage of the inaugural function, for which presidential remarks will be a guiding force and show direction of flow for growth and development of medical college as well as university. Dr. R.S. Mudol, Honorable Vice Chancellor, will deliver presidential remarks.
Very good morning to one and all. Dignitaries on the dais, off the dais, resource persons, faculty members, students, family members of Dr. C.R. Bidri, Madam Asha Patil, and Dr. Rajendra Bidri. I am here to pay the rich tributes to such a personality. Dr. C.R. Bidri is a multifaceted personality. Just to go down the line, any management wants to start a medical college especially, some stalwart who knows the medical gambit, rather what is the medicine and what is the society and what is that we are going to do a medical college. If I remember, founder dean and very good medical person, the BLDE association got to advise them, and he was a founder dean. I remember in 1986, this came into force medical college. And if I remember, in northern Karnataka, one more medical college, Jawaharlal Nehru Medical College of Belgaum, there was Dr. Jirge who was founder dean. Even though management has got everything, but a good advisor is required to start the medical college. That's how he was a founder dean. And today, whatever we are enjoying, academics, then all the conferences, then training the students and helping the patients, it's possible. And it is one of the jewel of the BLD Association, BM Patil Medical College. That to happen, we have to remember the founding persons. Along with we have to remember founders of the BLD Association. Along with that, medical college, we have to remember Dr. C.R. Bidri, his contribution. And it is every year we are doing the CME, state level CME, especially on the oncology. It is a great tribute to such a personality. And I remember again down the line, how he was as a parent, how he was as a physician, how he was as an astute administrator. When I was here in KCP Science College as a student, happened to be his patient, and his way of treating was entirely different. Entirely different. And probably one example of looking him, that day I got stimulated, should I become doctor like him? That is one thing. When Dr. R.B. Patil came for one of the college day of the KCP Science College, he was such a great personality from Hubli and North Karnataka. Dr. C.R. Bidri, Dr. R.B. Patil, and in Belgaum, Dr. Sangappa Desai, and in Hubli again, the Dr. N.K. Chennappa, Davanagiri Gurupadappa. These are the stalwarts. People used to say, always look up to them for their diagnosis, their treatment, their humanitarian considerations. Such people are there, any medical college or anything has to happen. Today, medical college can do wonderful training of the doctors in a very methodic way and become good doctors. And today we are very happy that last 38 years, this college has produced many of the good students. And when we meet for the alumni meets, recently one happened, all over the globe students are there. Always they remember the former deans, former teachers. That to happen, the legacy is there in the family legacy. And Dr. Rajendra Bidri was student in Jawaharlal Nehru Medical College. He used to come as a parent. I think without many parents today we call when students have got problem. Myself and principal find difficulty. Parents will not come only, but he used to visit regularly to his hostel room also he used to use it. And when he was postgraduate also he used to come regularly. That's what Dr. Rajendra has said. As a parent he has done, as a physician he has done his human service to the society and to the Vijayapura city. He would have settled in very good cities like Mumbai, cities, those days from the Grand Medical College, S.G. Desai and Dr. C.R. Bidri were good friends. They would have settled in very good cities and they would have made fortune and they would have settled abroad also. Why they came to these places, especially to the Bijapur, when it was very drought prone and nobody used to settle, even qualified MBBS doctors used to hesitate to come. And that time, he himself was a physician, a pediatrician. He came and settled, he changed, and probably because of his advice and management has taken and medical college has come today. And probably because of Dr. Jirge and all advice there, Jawaharlal Nehru Medical College. Like that, we have to remember people who have contributed not only to that area or that medical college, that has changed the perspective of the whole region. And today, where we are getting NRI students trained here, and all over the India students we get, that to happen, somebody has sowed the seed on that day, and we have to remember those people. Subsequently, many deans like Dr. Ranade, Dr. Karihold, and Dr. the Nagalotimat, Dr. M.S. Berada, Rajendra, and today Dr. Arvind Patil. They all are heading the legacy, what has happened. And we are today, we are very proudly, we say that we have gone advanced in the treatment, we have gone in training program also. And as the Chancellor has permitted us, we are going to come out with the 100-bed exclusive cancer hospital. And we have gone to meeting with the stalwarts like Shekhar Patil and all, his team. And shortly we are going to have the PET scan also. In existing building only we'll put the PET scan. And I think 4th or 7th we are going to put the foundation stone for the super specialty hospital, including cancer hospital, and also the auditorium, convention center with the classroom complex. That will happen, and management has given the permission for that. I am very happy to be associated with these programs. Last 3 years I am here, 3 programs I have seen. Year by year it is increasing in perception, in the resource persons, and people are very much being helped by this CME. And Asha Patil madam, every time she phones up and Dr. Tayar Madidri ilri ella nodri cholo agbeku anteli. So see how the MP Patil sir and Asha Patil madam, they are working towards the society and towards the medical college growth. And it's all of our duty, all the students and the faculty members, to strengthen their hand. And the motive of the social service has to be kept as the highest. And we have to produce a quality doctors and a patient care. My earnest request to all of the staff members that legacy has to be continued. What that day CR Bidri sir has shown, the seed, we have to grow it, and we are getting the fruits now. We have to work in his footsteps and bring the laurels to this institution. I am very happy to be a presiding officer of this CME, and all will be benefited. I think today we are going to get knowledge about the cancer, and we are going to start, madam, in his name, a dermato-onco clinic in Dr. CR Bidri, the name, will start, and that will be in the dermatology cancer. And there are head and neck cancer, there is abdominal cancer, gyne oncology is there. We are sub-specialty. We are today, as a mark of his respect to his legacy and his contribution, we are naming one clinic today, Dermo-Onco Clinic in Center of Excellence Dermatology. I request Dr. Inamdar to say a few words and tell about that, what we are going to do. With this, I conclude my remarks, and will grow in leaps and bounds with his philosophy and very benevolent and proactive management. And MB Patil sir is seeing always what next you want to do, what best you want to do. We'll assure that whatever possible, that will be done according to their wishes. Once again, I pay my richest tribute to the very stalwart late Dr. CR Bidri. Thank you, one and all.
Thank you, sir. Now I request Dr. Arun Inamdar, Pro Vice Chancellor, to say a few words on today's program.
Dignitaries on the dais and off the dais, I'm very happy to be part of this CMA on oncology. As respected or Honorable Vice Chancellor has told, we were just, in fact, already we had thought of it. A clinic would be there on oncodermatology, which is upcoming branch, and lot of basal cell carcinomas and other things we see in our OPDs. In fact, we have published a good number of papers on BCC. We thought we'll have a separate oncodermatology clinic on the name of Dr. CR Bidri sir. Everybody claims him as physician, pediatrician, but I claim him as a dermatologist also, because he was a dermatologist and the first HOD of my department, where I continued the legacy. I think this should be the best tribute which we can give from my department, or as an administrator from university, I thought I would do it. There are various ways by which we can think of oncodermatology, and we wish to establish one photodynamic therapy, PDT, which is a new entity in treating various cutaneous tumors. I will work out with the administrators. In fact, already I have visited a place in Germany where they produce this PDL, and I am in talk with them. We'll work it out and see that it becomes the best clinic also. I'm sure my head of the department, Professor Keshav Murthy, will agree with me for all these things. Thank you very much.
Thank you, sir. We request dignitaries on the dais to please come and occupy their seats in the auditorium, as we have another significant program before the conclusion of the inaugural program. In view of this, we request the guest faculty, Dr. Lohit Ji, Dr. Abhilasha Narayan, Dr. Prabhu N. Nesargikar, Dr. Natraj, to come on dais to be briefly introduced and felicitated. Madam, sir, please.
Mrs. Asha Patil, as a special representative of Dr. CR Bidri family, is called upon and please come and felicitate Dr. Abhilasha Narayan.
Okay, pass here. Huh? Call mic in, beta. Slides.
Dr. Lohit G will be felicitated by Dr. Hesen Bentur, Head of the Department of Medicine. I request you to please come forward, sir.
Dr. H.T. Lata Devi, Chairman of Scientific and Academic Research Society.
Dr. Lohit G will be felicitated by Dr. S.N. Bentur, Head of the Department of Medicine. I request you to please come forward, sir.
Dr. H.T. Lata Devi, Chairman of Scientific and Academic Research Society, will felicitate Dr. Prabhu N. Nesargikar.
Yes, sir.
Dr. Natraj K.S. will be felicitated by Dr. Shailaja Bidri, Head of Department of Obstetrics and Gynecology, who is both faculty and representative of Dr. C.R. Bidri family.
The inaugural function concludes with expression of gratitude to all the dignitaries, delegates, faculty, students and staff who have in one way or the other ensured the success of this continuing medical education program. Dr. R.V. Kulkarni, Registrar BLDE deemed to be University, will now deliver the vote of thanks.
A very good morning to one and all present here. Thank you is such a prayer that cannot be seen or touched. It must be felt by the heart. I take this opportunity to thank everyone who has contributed in the successful organization of this Dr. C.R. Bidri Memorial State Level CME on Oncology. On behalf of the organizing committee and BLD deemed to be University, I convey my deep regards and heartfelt thanks to our Honorable Chief Guest and Pro-Chancellor, Professor Y.M. Jayaraj, for having accepted our invitation and sharing his valuable thoughts. It was truly inspirational, sir. Thank you very much. I extend heartfelt thanks to our Honorable Vice Chancellor, Professor R.S. Mudhod, who has kindly accepted to preside over the function. His constant support and guidance has that radiated a source of energy within us and made this CME a great success. Thank you, sir. Thank you very much. My words are not enough to express gratitude towards Srimati Asha Patil Madam for gracing this function, who is always a source of inspiration and guiding force for all of us. Madam, on behalf of BLD University, we thank you for your endowment fund donation to our university for a noble cause, that for treating the poor patients, academic excellences, and sports. Thank you, Madam. I thank the convener of this state level CME, Dr. R.C. Bidri sir, who has put his hard efforts meticulously since more than a month to organize this event, including the selection of speakers who are the stalwarts in their chosen field of practice. Thank you so much, sir. I extend a very heartfelt gratitude to all the speakers, Dr. Lohit, Dr. Abhilasha, Dr. Prabhu, and Dr. Nataraj, who have traveled from the far distance to share their valuable experiences in this CME. Thank you so much, sir. I thank Pro Vice Chancellor Dr. Aruni Ramdar sir for his guidance and suggestions. I thank Principal Dr. Arvind Patil, Vice Principal Dr. M.B. Patil for extending all the support and constant encouragement in organization of this CME. Thank you, sir. Thank you very much. I thank Dr. S.N. Bentur, HOD of Medicine Department, and Organizing Secretary Dr. Rajesh Vannutgi for their untired efforts in organizing this seminar. I sincerely acknowledge the supports of Dr. S.T. Lata Devi, Vinay Katti, and Dr. Anuja from the SARS. I would like to thank all the special invitees, delegates, faculty members of this institute, and faculty members from sister concerned institutions in attending this seminar. An event of this dimension cannot happen overnight. The wheel starts rolling months in advance. We have been fortunate enough to have the dedicated team of volunteers. I thank one and all for their efforts. If the time is money, then today we all are spending in millions in sharing our knowledges. Have a wonderful academic fest. Thank you. Thank you so much.
Thank you, sir. We shall take a short tea break to reorganize the hall for presentations by each guest speakers. We request the audience to please reassemble within 10 minutes of break to help in continuity of the program.
ಮಾಡಿ ಬರ್ರಿ ಅಂತ ಹೇಳ್ರಿ ಪ್ಲೀಸ್ ಆಕ್ಯುಪೈ ದ ಸೀಟ್ ಅಂತ ಹೇಳಿ ಚಂತಾನ ಇಲ್ಲಾಂದ್ರೆ ಇಲ್ಲ ಯಾಡಾತ ಮಾಡ್ರಿ ಅನೌನ್ಸ್ ಮಾಡು ಬಾತೇಳಿ ಎಲ್ಲರಿಗೆ ಚಲ್ ಮಾಡೋಣ ಮಾಡು
I request everyone to come back and occupy your seats so that
ಅಲ್ಲೇ ಕೊಡ್ತಾರೆ ಚಾ ಕೊಡ್ಬೇಕು ಮಾಡಿ ಇನ್ನೊಂದು ನಾಲ್ಕು ಕಂಟಿನ್ಯೂ ಮಾಡು
I request everyone to please occupy their seats.
I request everyone to assemble in the hall and assemble in the hall and occupy the seats.
I request everyone to reassemble in the hall.
what is this? Where will you put them? I request everyone to please reassemble in the gallery and occupy their seats.
Start the program.
I request everyone to please reassemble in the gallery and occupy your seats.
Welcome back. I request you all to be seated. I am sure that you will accept our request to maintain silence for the peaceful conduct of this scientific program.
Continuing medical education is an important part of today's medical practice and treatment, as There are numerous technological advances, investigative advantages, and modalities for the treatment and diagnosis which aid in the treatment of patients. In view of this, the continuing medical education program encompassing the field of oncology will enlighten the practitioners, faculty, and students' approach to patients both in terms of treatment and supportive care which is available for them.
However, all said and done, the true prayer of treating doctors has not and will not change. I would like to quote a physician's prayer by a very senior, prominent specialist and a teacher, which is relevant for today's event. I present it to you as follows. From inability to let well alone, from too much zeal for the new, and contempt for what is old, from putting knowledge before wisdom, from putting knowledge before wisdom, science before art, and cleverness before common sense, from treating patients as cases, and from making the cure of the disease more grievous than the endurance of the same. I repeat, from treating the patients as cases, and from making the cure of the disease more grievous than the endurance of the same. Good Lord, deliver us. This is the aim, essence, and need of science and art of medicine for patient care. With this note, we'll begin the scientific program.
I would like to invite Dr. Suresh Kanamadi, Department of Radiology, to chair the session on recent advances in radiation oncology and introduce our first guest speaker, Dr. Lohit G. I hand over the proceedings to the chairman.
Hello. 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 Good morning to all. Thank you giving a good opportunity for me to chair this session. One important session this is. I introduce Dr. Lohit G, who is qualified in DNB Radiology Oncology and is fellow in ESMO. Sir, Dr. Lohit G heads the Precision Oncology Initiative at HSG, dealing with the radionomics and radiogenomics to facilitate personal cancer therapy. In medical breakthrough, Dr. Lohit Reddy sir has come up with multiple immunoradiotherapy combinations that support efficient management of multiple cancer types. He is a member of European Society of Medical Oncology. Sir, he was invited as a faculty at Harvard Business School, Boston, USA. Sir has many awards and accolades. Dr. Lohit G has completed a fellowship on proton and carbon ion from a reputed institute at Pavia, Italy. Sir, Dr. Lohit is a recipient of various prestigious awards such as Research Award from ESMO and Award for Research from the Society of Neuro-Oncology at Scotland, USA. Recently, Sir got award from CDAC Pune for innovative in artificial intelligence. I welcome you, sir, for starting this all-important session.
Thank you. It's been a privilege to be invited for an exciting CME in remembrance of Dr. Bidri. So thank you to the faculty for inviting us for such an exciting CME on oncology. And we are very, very happy to hear that you're coming up with an oncology center, and it's absolutely needed, having such a big medical college and to cater to this population. So today I'll be speaking about how radiation oncology has evolved in the past few decades and what is the latest research which we are doing at HCG and how it is impacting our patients. I will be showing some clinical examples as well. How we are moving away from generalized medicine to more precision medicine, because I am very different from you. So your genomics, your proteomics, your metabolomics are completely different compared to mine. So every patient is so different, so you have to customize the treatment and personalize the treatment, which is absolutely the most important thing right now in cancer. So what are the latest 4 Ps in modern cancer treatment? I think the main focus is more proactive rather than reactive. In the past decade, oncology practice was all reactive. We were waiting for recurrences to happen. We were waiting for metastasis to happen. The staging used to be more regressive than aggressive. So now we are more into proactive medicine. There is a lot of focus on prevention. Like for example, yesterday in the budget session, Mrs. Nirmala Sitharaman spoke about starting off a cancer vaccine for cervical cancer. So that is going to be a governmental program. So now there's more focus on prevention using vaccinations, giving a lot of thought on food quality, reducing the pesticides, the soil quality. So there's a lot of impetus given to prevent. Okay. So there's a lot of talk, and the most important thing is prevention. Coming to the other piece, prediction. If a cancer patient comes into my clinic with stage 1, what are the chances of that patient coming back with a recurrence or a metastasis? Can that patient be predicted for the aggressiveness of the tumor? What is the heterogeneity of the tumor? Even with one single tumor, there could be hundreds of gene mutations in one single tumor. And that is possible with the usage of artificial intelligence. There's a lot of computing technology which is coming to the fore, where we can in advance predict what is the aggressiveness of the tumor or what are the chances of that patient coming back with a stage 4 disease again. The third is the precision. If you see specifically with medical oncology and the radiation oncology, in the past decade, there is a lot of development which has happened into technology. We were just, if there was an head and neck cancer, people used to say, even now patients who come from rural backgrounds say, sir, current korta idira. So it is not current, we are only giving x-rays. And now there are focused ways to give x-rays to the exact location. We know the patterns of spread of the disease, and accordingly we precisely treat the area of intent and reduce the side effect profile of the patient. So the treatment is highly precise. With respect to medical oncology, we are moving away from chemotherapy. In the last decade, there is not even one single chemotherapy drug which has come into the market. It is only targeted therapy. Like for example, you take a lung cancer. Lung cancer, if there's a EGFR mutation, you have a targeted drug which is gefitinib, afatinib. Then these are the drugs which osimertinib. So these are the drugs which only focus on the EGFR mutation and destroys the tumor and have very good quality of life with least amount of side effects. The same thing with ALK mutations in lung. You have advanced drugs like crizotinib, we have selitinib, we have new drugs, lorlatinib. So these are the drugs which are highly focused. So you don't have to give chemotherapy which is considered to be very, very toxic. And we have moved away from that era to a new precise era. And as I told about personalized medicine, everything right now is moving towards genomic-based medicine. We are talking about staging right now. We are still in the staging phase. But if you see, the next staging phase will be all about usage of genomics. Use a specific genomics, and then probably the patient will be staged accordingly. And the treatments also will be customized based on individual patient rather than giving generalized chemotherapy and giving the toxicity. So this is the main crux of proactive medicine. So what are the clinical challenges as an oncologist? What we face in the clinic is, the toxicity. The most common thing is toxicity. So with chemotherapy, with targeted therapies, there could be toxicities. If you're treating head and neck cancers, or if you're treating cervical cancers or breast cancers, there's significant toxicity with respect to mucositis, with respect to loose stools, with respect to a lot of fatigue. So toxicity is one of the main concerns for patients. The other important thing is resistance. Why do we say no cure for cancer? It is because we know that cancer, even if it is stage 1, there's always a chance of it coming back. There's a certain percentage of chance it can come back. So that is due to resistant mechanisms which our body takes up due to certain mutations which happens in certain genes which can lead to resistance. The third is the heterogeneity. What I mean by heterogeneity is even within a single tumor, there could be hundreds of mutations. So for example, I told you about lung cancer, EGFR targeting agents. Even in one single cancer, there could be three or four genes which can lead to recurrences, which can lead to resistance, and it is a big, big problem. The other most exciting where we are doing extensive research is organ-specific metastasis. If you see head and neck cancers, from the tongue cancer, mostly 99% of the patients will have only lymph nodal metastasis. They don't go below the clavicle. In cervical cancers, it's usually lymph nodes and across the parametrium. In prostate cancer, through the vertebral plexus, it goes into the bones. And why is it so well programmed that a specific organ is programmed for organ-specific metastasis? The concept is seed and soil hypothesis, but it is more complicated. It's very easy to say seed and soil hypothesis. What I mean by seed and soil hypothesis is if there is a cancer in prostate, it means that there is a signal which is being given by the vertebral plexus to go into the specific bones. So it means there is soil there for proper growth of the tumors. And that is an exciting scope of research wherein we are trying to map why certain cancers only go to that area and why doesn't it go to the liver or why doesn't it go to the brain like in breast cancers or colon cancers. So awareness of cancer is itself at a very nascent stage. There's still a lot of scope for research, and especially youngsters sitting here, there is a lot of motivation in cancer. If you're interested and excited in exploring the chances of research, I think this is the one specialty which is very exciting. So as I told you, the right medication at the right dose for the right patient is absolutely necessary. And right now, all the drugs are in the personalized medicine space. And customization of treatment is absolutely important. So my talk will be on advances in technology, advances in imaging, and advances in concept, and what research we are doing. So radiation oncology, we usually treat in schedules. So our radiation treatment will be for a total of 30 to 35 days in a radical setting, Monday to Friday, every day, probably around 10 to 12 minutes. Patients will come, take treatment, and get back. So Saturday, Sunday would be an off. That is for the recovery of the patients. So ultimately, what we are looking at is destroying the DNA of the cancer cell by treating the area of interest and areas of potential spread, either in a radical setting or in post-op setting, or also in palliative setting to reduce the pain or to reduce the bleeding. So the most important thing is to improve the tumor control and the normal tissue complications to be as minimal as possible. So in the past decades, the evolution of radiation from the 1950s and 1960s, as I told you, sir, current korta idira. So we used to just draw it on the X-ray portal. We used to deliver radiation, the skin toxicities to the bowel toxicities to, it was extreme. Patients would not tolerate these kinds of treatment. 1970s, we went into high energy linacs, wherein there was a little bit of focus, but not to that extent, but it was manageable. And then came the advent of good imaging technology, good computational technology, wherein we could see where the cancers are, where are the spread, and accordingly we used to map the tumors, and it used to be extremely focused. And now we are in an era of artificial intelligence, wherein we can even pinpoint and predict what are the chances of that patient coming back and exactly pinpoint our focus and adapt to the changes which the cancer, adapt to the challenges and the changes which the cancer gives. So this is how we used to treat before. And this used to be the toxicities to the patients. And now, if you see the image, if you see the image, conventional RT, this is a cervical cancer patient. Sorry. So this is a cervical cancer patient. So here you can see a lot of bowel, everything getting a lot of dose. But now with advanced technology, you can see the shaping of the field. Only the lymph nodal chains are exactly treated and the bowel is completely spared. So the toxicity is a lot lesser. This is an head and neck cancer patient, wherein you can see the whole head and neck cancer, head and neck area is completely getting radiation. Whereas here in the advanced technology, you can see the minor salivary gland to a certain extent spared, the spinal cord spared, the parotids are spared, so that the xerostomias, the myelopathies, and the mandibular necrosis is always going to be on a lower extent. So the Vice Chancellor, sir, was talking about something called as PET-CT. So I'll come to the imaging technology. So Vijayapura is shortly going to have a PET-CT as well. So from CT scans, we have moved to molecular imaging. What we do in our setup is, rather than just having glucose-based PET CT scans, we have multiple PET CT scans. The advantage of PET CT scan is the whole body will be scanned. So we can exactly know, even if in certain head and neck cancers or cervical cancers, there could be 1 or 2% of the patients who will have metastasis elsewhere. So it's absolutely important to stage the patient appropriately and correctly. So here you can see the PET CT scans. This patient has multiple nodal metastases, one in the mediastinum, one in the para-aortic region, and one in the pelvic region. So it's very, very important to map the tumor. And this also helps the radiation oncologist to map the tumor, to draw the tumor, and then deliver a radiation to the pinpoint area rather than, giving only to the areas, larger areas, and control the side effects to an effective way. So again, here is an head and neck cancer patient, a nasopharynx case. Only the nasopharyngeal area, you can see the normal brain, the temporal lobes, everything completely spared. And patients tend to do very well over longer periods of time. So this is again an hypopharyngeal cancer patient, a smoker, came in with stage 3 disease with a neck node, PET CT imaging, easily determining the size of the disease, the location of the disease, the involvement of the disease, so we can accurately stage. And here you can see post chemo and radiation, we have very good control rates and no disease. This is almost, now it's in 2017, the patient is still doing well at 2024. Recently he has developed lung cancer. So we're treating for lung cancer and we have put him on EGFR drug right now. One other thing is MRI. We also use a fusion of MRI and PET CT scans for soft tissue utilization. So here you can see the head and neck tumor or laryngeal tumor, and then here you can see better visualization using MRI. So this is one of the machines, some of the machines what we use at our hospital. So here is a machine which is a CT scanner which is incorporated into a linear accelerator. So during the treatment over a period of 35 days, we can exactly see what is happening to the tumor, whether it is shrinking, if there is growing during the tumor. And we map on a daily basis and we exactly focus a tumor. This is a lung cancer patient. You can see exactly matching is happening and we will deliver the treatment to the area of intended thing. And during the course of the treatment, even if there is a shrinkage, so in the 8th day, so there is good shrinkage in this patient and we try to change the contour so that the side effect profile is very less and we know if the biological response of the tumor is adequate or not. If at all it is not, then probably we have to increase the dose accordingly. So we customize our treatments based on that. Coming to some of the other exciting researches what we do. So many patients come with brain metastasis. Breast cancer with brain metastasis, colon cancer with brain metastasis, lung cancer with brain metastasis. The most important thing what happens when we give brain radiation is cognitive deficiencies and memory disturbances. So what we have developed is something called as hippocampal sparing radiation. So here you can see these are the hippocampus. Hippocampus helps in cognitive efficiency of an individual. So what we do in radiation is we spare the hippocampus and we only treat the brain parenchyma, and that helps in very good quality of life of the patients, because even with patients with brain metastasis, people tend to live for long with targeted therapy, with immunotherapies. So we have to be very careful on quality of life. It's not just looking at cure rates, it's also about maintaining quality of life. So these are some of the breast cancer thing. We used to see a lot of breast cancer reactions. Now we have evolved from giving 35 days of radiation to just 19 days of radiation, and we have had around 700 patients wherein we have very, very good results, and this is published at Astro. Carcinoma cervix, even with stage 3B and 4, this is one tumor, if correctly treated, will have excellent control rate, especially in the rural setup. Lack of hygiene, HPV related infections leads to carcinoma cervix, and with the advent of radiation, radiation is one of the mainstays of treatment in local as well as loco-regional carcinoma cervix, and here you can see the responses in our setup is around 98% with the usage of EBRT, cisplatin and brachytherapy. So this is the newer armory into our setup. So where we use human intelligence linked with artificial intelligence, and the advantage is, as I told you, every day we take an image, and this is a cervical cancer. Here is the bladder, here is the rectum. So even based on your rectal filling and bladder filling, if you have to treat this, there's always going to be changes. And this machine using artificial intelligence helps us to exactly map even intra-second what happens during every second. Even if certain movement is happening, we exactly map the tumor and treat. And this is how accurate it is. So the side effects are absolutely very low compared to the traditional technology. So this is how we map and we treat. And this is, you can see the carcinoma supraglottis, pretty good shrinkage at around 20 fractions. So I was speaking about the regular technology. What we have is another machine which is CyberKnife. So I spoke to you about the technology which was about giving radiation for 35 days. Now we are more into pinpoint radiation. If the previous technologies was like routine beam, like a torchlight, now we are into pencil beam, which is very, very focused. And this focused radiation will be given only in 3 to 5 days. We give very high dose of radiation to a very focused area of intent, and that there will be complete destruction of the tumor. And this also has an advantage in the era of immunotherapy, wherein it can create an immune impact and give a very good response to the tumor. So these are some of our patients where recurrent tumors are easily mapped by CyberKnife, 5 days of radiation with chemotherapy, immunotherapy, or targeted therapy with excellent responses. This is a trigeminal neuralgia. It's also called suicidal disease. In a very critical area, there is always going to be compression of the trigeminal nerve, and there's going to be paresthesias and severe pain in the area of trigeminal nervations. So here we give one single fraction very close to the brainstem, sparing the brainstem with complete pain relief within the next day. So AVMs, arteriovenous malformations. So the niduses are going to be ablated, and the bleeding risk is reduced, and this will be done in 3 days of treatment. Pituitary adenomas, both secreting as well as non-secreting. Again, 3 to 5 days of radiation. The control of tumor is going to be very optimum. So the next is the most important thing and the most exciting thing. I think in the recent newspaper article, probably a year ago, you would have read, most of you had read that rectal cancers are completely cured based on a trial in the US. So that is based on one immunotherapy drug. Total 18 patients had complete regression just by immunotherapy drug. So the inward and the most exciting thing about oncology right now is immunotherapy. What I mean by immunotherapy is cancer is mainly caused by an interplay between your immune system and your normal cell proliferation. So if you try to, if there is a manipulation of your immune system, then obviously there's going to be proliferation of your normal cell. So what immunotherapy does is you are giving immunotherapy from an external route, so that you're potentiating your body's immune system to fight against cancer and detect against cancer. And right now we have 2 immunotherapy based drugs, which is PD-1, PD-L1 inhibitors, and the second is CTLA-4 inhibitors. These are approved drugs which are creating a great response. And if you see immunotherapy at present, out of 100 patients, 25 patients will have phenomenal response. The remaining 75 patients don't have good response. And that is where radiation comes in, wherein radiation acts as an immunotherapy sensitizing agent, which potentiates the effect of immunotherapy drugs, because this immunotherapy is very expensive. For every 15 days, it costs around 4 lakhs. So it has to be effective. So we have to give it at least for a minimum of 6 cycles, and in some patients, lifelong treatments. So this is a very expensive treatment, and we have to potentiate the effect of immunotherapy, and that is where radiation comes in. So this is one of the immune cycles what we have developed, and we have presented it at Paris, wherein there is a lot of interplay between lymph nodes, T cells, dendritic cells, and how we potentiate body's immune system to fight against cancer. So these are some of the combinations what we've used with immunotherapy and radiation. This is one of our patients, severe bleeding, melanoma studied everywhere. And after 3 cycles of immunotherapy, we have given radiation for the bleeding, and there is pretty good regression of the tumor. Hepatocellular carcinomas, usually immunotherapy is going to be very, very effective in viral diseases. So this is an hepatitis B patient, hepatocellular carcinoma, and after immunotherapy, the patient also had portal vein thrombosis, not a transplant candidate, and we have given immunotherapy and radiation, and patient is disease-free even now. So nasopharynx, again, EBV virus-related disease, a lymph node here in the supraclavicular region after immunotherapy and radiation, pretty good response. So lung cancers with targeted immunotherapy has become one of the standard, and with very, very good responses, even in the metastatic sites and also in the primary site. So this is, if you see, this is one of our patients wherein a lung cancer with liver metastasis, stage 4 disease, given immunotherapy, there is regression of the primary site as well as all the liver metastases are completely gone, and patient's quality of life is excellent with less amount of side effects. So I'll give two cases of how immunotherapy has created an impact and how targeted therapy and genomics has created an impact. A 70-year-old lady treated for endometrial adenocarcinoma, post-surgery, these are the risk factors. The only risk factor was greater than 50% of the myometrium. We had given radiation. After 3 years, patient has come back with the disease. So it was 6.7 into 4.7 centimeter, loco-regionally very aggressive and infiltrating and eroding the acetabulum. It was mainly in the pelvis. And again, there are, multiple deposits in the muscles as well. And also there were lymph nodes. Usually, probably if the patient would have come to me for 5 years ago, we would have told, okay, go back home, live your last life. We would have given painkillers and just managed them with painkillers and let her die. But now we have moved away from just telling the patient to go home and die. No, that is not the way. Even stage 4 is controllable, is treatable, and patients do tend to live over a longer period of time with excellent quality of life. So that is absolutely important right now in oncology. And here in this patient, we did some genomics. And we started her on chemotherapy with a targeted drug based on the genomic profile. And here you can see the response. All the sites have vanished. Okay, on the left is all the deposits. On the right is the response. So now patient is pain-free. Patient has done very well and with excellent quality of life. So this is a farmer's son from Mandya, poorly differentiated squamous cell carcinoma in the sinonasal region, a very aggressive tumor. The standard protocol was followed. We did CTRT, we did gefitinib for maintenance, and then put him on capecitabine tablet. And the patient came back with disease, a very young 25-year-old gentleman. And after gene testing, we did gene testing for this patient, considering the age of the patient. And in the patient, this gene was present. What this gene meant is the tumor is very, very aggressive. And if the gene is, we tried to find out if there is any drug pertinent to this gene, but we couldn't find any gene. So we also did the PDL1 expression, which is an immunotherapy expression, which was negative. But we again discussed in the tumor board, irrespective of being negative, we still arranged for immunotherapy based on humanitarian grounds, gave him free treatment. And here you can see he came in with a stretcher in a recurrent setting. And after immunotherapy, there is very good regression. And he was working with us for 6 months in our front desk, and then he succumbed to the disease recently. So this is again one of our ovarian cancers, just by one injection of FAPI. This is a new theranostic modality based on the PET imaging. Ascites, very, very debilitating condition, having ascites, daily tapping or alternative day tapping in ovarian cancers. And just after giving one injection of FAPI, the ascites has completely vanished, and now patient is on platinum-based treatment with very good quality of life. So the most important thing is it is not just one doctor giving treatment. In our hospital, it is always about multidisciplinary approach. So the medical oncologist, the surgical oncologist, the radiation oncologist discuss each case, come to a conclusive evidence, and then based on each evidence, we try to treat individual patients. And that is the most important thing. Doctor cannot give 5-minute prescription. It's very easy to give 5-minute prescription, but oncology is not like that. It's an enigma. So there needs to be depth in delivering of treatment and to decide on treatment. So that is absolutely necessary, and hence multidisciplinary approach and virtual tumor boards. Tumor boards are absolutely important to discuss each and every single case, even if it is cervical cancer stage 1, every patient has to be discussed and then gone ahead. And other thing is we also monitor and drive outcomes. So we also monitor what are our outcomes, how can we change our outcomes. If a certain disease has lower outcomes, how do we adapt to that and improve outcomes is the most important thing. So as I told you, stage 4 is not a death sentence. It's still amenable to treatment. We still have a lot of treatment strategies. Newer treatments are coming to the fore, and stage 4 is still treatable. So coming to the most simpler and exciting thing is, if you see genes, if you see this elephant does not get cancer. That is because it has p53 genes in 40 alleles. Okay, so p53 is the gatekeeper of our genome. So usually it is very, very, very rare for all the 40 genes. If one gene is mutated, then probably the other gene will take over and protect the elephant of cancer. So whales as well. So these large mammals have huge amount of alleles of p53 gene, and very, very rare to get tumor. And humans, we only have one gene, which is one gene of p53, and that is when we are more prone to cancer. And based on this, the food we eat, the amount of pollution what we have done to our environment releases a lot of free radicals, and it is an ongoing process in our body wherein we have mutations in our body, and that tends to give rise to cancer. How does our body recover? We also have a lot of antioxidants. Our immune system releases a lot of antioxidants that helps in destroying and controlling these free electrons, so that the mutations are repaired and the chances of we getting cancer is going to be a lot lesser. So the other most important thing is repeated inflammation. If you see continuous gastritis, if at all there is a lot of irritation, or if it is viral infected, inflammation is the root cause of cancer. Tobacco chewer, chronic irritation of the mucosa, or stasis in the rectum, lot of irritation in the rectum. So these are all root causes of cancer. And now coming to the other aspect of metabolomics. If you see our olden time rishis, they used to have just food one time. Okay, and why is that significant in my talk? Because our diet plays a very, very important role. Fasting plays a very important role. You reduce your glucose content, you reduce your carb content, we are moving into more amount of low carb diet and keto diet. So this definitely helps in cancer, because what happens is the metabolic pathways, and if you see the mitochondria, it is altered in cancer cells. So by starving the cancer cells, probably the response could be much, much better. The response to the mainstream treatments are going to be much, much better. And this is one exciting phase of research wherein fasting-based radiation, fasting-based chemotherapy can be tried, wherein there could be response. So you finish your dinner at 6 o'clock and again start your breakfast at 7 o'clock. So you have a 12 to 13 year fasting period. So probably it'll take some time for the patient to get acclimatized, but over a period of 1 to 2 weeks, patients do tend to tolerate pretty well. And we have had very young patients who have responded to this concept excellently. So coming to my last phase, so this is the research what I do, so artificial intelligence and radiomics. So if a patient walks into my clinic with a PET-CT scan, can I say what are the chances of that patient coming to me with a disease after 2 years? So here is a head and neck cancer, and here we try to do something called as radiomics, which is going behind the image and trying to find imaging biomarkers. It's not just blood biomarkers, we can create imaging biomarkers. So we found 2 imaging biomarkers, which is V90 and extent, just based on my PET image, with a specificity of 93% and 87% to predict the chances of patient having local recurrences at diagnosis. And this is published and this is awarded by CDAC recently. So these are some of the decision support systems what we are developing, and machine learning, omics, how do we define the risk groups, and this is all possible with artificial intelligence, taking big data, trying to customize treatments and see which cancer patients falls to which risk group and how we can customize the treatment. So we again genomic based radiation, and here is the publication, some of the publications what we have done. So to conclude, I think there are a lot of youngsters. Just one message for the youngsters: the future starts today and tomorrow. I think the advantage in India we have is the number of patients we see. We have trained in the West. We have seen there's not much of patient load there. Here the advantage is we have huge amount of load. And right now we are in an era of research. We can do ultimate research. There is lot of human resources, there's lot of technology with us, and you youngsters are there in the era where you can use this technology, you can use your data, you can use your patient resources to the optimum and create impact. It's not just following the West. I think the West will follow the East, because for us the advantage is patience. Our load is huge and the learning is huge. And rather than following the West, I think we have to make the West follow us. So the future starts today and not tomorrow. Thank you.
Thank you, sir, for enlightening us with recent advances in radiation oncology and precision oncology. I request the chairperson to kindly present certificate of participation to the guest speaker.
Any questions? Kindly raise your hands. Yeah.
Yeah.
Give.
So PET scan is molecular.
Metastasis.
No, PET scan is molecular imaging.
Yes.
PET scan is used both to determine the loco-regional spread of the disease as well as to determine any metastasis. So what we do in PET CT scan is we inject a isotope tagged with glucose. We tag it with FDG, okay, which is glucose molecule, because 95% of our patients, 95% of the cancer depends on glucose metabolism for its development. So when we tag a glucose molecule with an isotope, it all gets accumulated in the tumor region and there is a glow. So that is where we can determine locally as well as in the systemic area if at all there are any metastasis. So that is the greatest advantage with PET CT. With, yeah.
Sir, another, if, for example, breast carcinoma is there, is that patient is recovered, how many times to do the follow-up? In follow-up, you will tell us.
So there are
PET
standard protocols, sir. So usually what we do is after the chemotherapy, radiation and surgery, if the patient is on hormonal treatment, the first scan will be done after 3 months. If the 3-month scan is normal, then we make it like yearly scan. Unless the patient has any symptoms, like for example, in the preceding time period, if at all the patient has a lot of headache, lot of back pain, then we tend to proceed, because we have to rule out if there are any metastasis in the preceding period. Otherwise, first 3 months, wait for 1 year, do 1 year, do another year of until 2 years, we do another annual scan. If 2 years are normal, then we would do it every 2 yearly. So that is the protocols what we follow.
Okay, sir. Thank you, sir.
Backside, one more is there.
Sir, I have a question to you.
Please.
Can we induce P53 gene alleles in human body? Is it possible?
Yeah, that's an exciting question. I think there is a lot of talk on something called as CRISPR. Right now, it's gene editing. Okay, that is Dr. Natraj's talk. So he'll be talking about CRISPR and gene editing. I think that is an area of interest, but there are a lot of ethical concerns with that concept. So it's still in a very advanced stage of research, and probably that is possible. Cloning and CRISPR gene editing is possible. But again, there could be other risks as well. You could induce other genetic diseases as well. So you'll have to be very, very careful, and there are a lot of ethical concerns with that. So that is the in thing.
So
that is
it's
where we're
happening.
moving. It is happening, definitely.
Thank you.
Yeah.
Dr. Rohit, the question. Immunotherapy and radiotherapy.
Where is the question coming from? Okay, sorry, sir. Yeah.
Immunotherapy and radiotherapy, how do you see they are complementary each other, or the organ specific, cancer specific? How do you?
So right now in India, HCG is the only place where we have an immunorad department. This is the only organization which is doing immunorad. So right now what we are doing is we only doing it in extremely metastatic diseases when all the treatment paradigms are failed. And there has been an evolution from 2016. I started doing this in 2016. So there have been challenges, there have been failures as well. But now we have come to a point wherein we have started seeing some excellent results. Like for example, in liver cancers, even with portal vein thrombosis, patients tend to do very, very well over longer periods of time. That is by a combination of immunotherapy and radiation. So, even liver cancers, renal cell cancers, melanomas, these are considered immunogenic tumors. And if at all regular immunotherapy is not working, that is when we add radiation so that it potentiates the effect of radiation. And radiation has to be given in a very specific way. We cannot give it for 35 days. We have to give it in 5 days, which is called SBRT or SRS.
And how do you see now targeted, we are talking about a lot of targeted therapy, whether it is radiotherapy or the the medical
oncology, yes.
oncology, or even the what you call now immunotherapy.
Yeah.
How do you see with conventional and targeted results?
I think it's excellent. It has changed the way how oncology has evolved. Now, if you see, as I told you, in the last decade, there's not even one single chemotherapy drug which has come to the market. It is all targeted therapy and immunotherapies. Because even if it is a metastatic disease, by just giving one drug, the side effect profile is so less, and the responses have been very, very phenomenal. Specifically with immunotherapy, if a patient responds, it is going to be so exaggerated and so well that sometimes we have seen complete vanishing of diseases using immunotherapy, which is unheard of in the chemotherapy era with so much of toxicity. So that is where it has created an impact.
Now, how do you see AI the helping in predictive precision or futuristic, whatever?
I think with AI, it is not going to replace human intelligence. What AI is going to do is it's going to augment your intelligence. Okay, so by using AI, probably the work what I used to do in 40 to 50 minutes can come down to probably 1 to 2 minutes. So your capabilities are going to be increased, and probably your accuracies are going to be increased, and the chances of verifications using artificial intelligence is going to increase.
Yeah, it is a complementary.
It is always augmentation and complementary.
Thank you. Very wonderful talk.
Thank you.
And enlightened all of us.
Yeah. One more question,
See, for example, in a particular group of cancer, you have taken some 40 cases of oral cancer. Genomics of a group of cancer is same, or genomics of an individual patient is different?
Excellent question. Genomics of you and me are different. So there is no group of cancers. It is even individual cancers are so different. Even an individual patient's genomics are so different. So we have seen two patients of oral cancers having the same stage, having the same location, having multiple gene mutations. That cancer could be caused by multiple genes. Okay, so even two individual cancers of same stage, same area is different. So that means two individual people will have different genomics, different proteomics, different metabolomics.
No, so my idea is two normal healthy individuals have different genomics, right?
Yes.
But when it develops into cancer,
Even
the
in
particular
cancer,
mutation may be.
No. Even in cancer, it is different.
Even in cancer,
Yes,
it's also different.
it is completely different.
So it is mandatory that each individual has to undergo genomic examination.
Yes.
But then how it is applicable to peripheral? This may
That
be,
is, I think now that's a very, very important question. So in the periphery, now the genomic costs are probably around 50,000. We can do the genomic evaluation. But using artificial intelligence, using technology, the cost is coming down. So probably in the next 2 years, it can come down to 5,000. Like a blood test, it can come down to 1,000 rupees. So obviously, if the machine is there in Vijayapura, you get a simple genomic profiling. Probably, you don't have to come to Bangalore for treatment of radiation. You can just take a pill in Vijayapura and get completely controlled with cancer. So that is a possibility. And that is where we're moving probably in the next 3 or 4 years. Even Vijayapura may have a genomic center. And probably government will take initiatives to subsidize and probably get a genomic evaluation center here, which can reduce the cost to a great extent. It could be like a simple blood test.
Thank you.
Thank you.
wants to ask? Yeah, one more is here.
Now, I request the chairperson to kindly present certificate of participation to the guest speaker. Now, the chairperson will receive the certificate from Dr. Vijayapura Kalyan Bugol, Medical Director of Super Speciality. Thank you, sir.
It's an immense pleasure to announce that the registrations for this CME has crossed 1,000 plus in number across the state. This marks a huge milestone for us as this is the largest number of registrations in our university. It is my honor to invite Dr. Shri Aliwal, Professor of OBG Department, to chair the session on recent advances in gynec cancers, which will be delivered by our distinguished speaker, Dr. Abhilasha Narayan.
Because I'm a little smaller, I like to stand on an elevated place. So, at the outset, I'd like to thank the organizers for inviting me to be to participate in this very exciting and advanced session. And I have the honor to introduce Dr. Abhilasha Narayanan. She has done her fellowship in gynae oncology from Kidwai, Bangalore. Dr. Abhilasha Narayanan is experienced consultant gynae oncologist and robotic and laparoscopic surgeon at HCG Cancer Institute, Bangalore. She is highly trained and certified in gynae oncology and specialized in treating cervical and ovarian cancers. Dr. Abhilasha also has extensive experience in colposcopy, administering chemotherapy, and palliative care management of cancer patients. She takes care in a collaborative approach and provides guidance and support to her patients throughout their treatment. Madam is also interested in academics and has many publications and presentations to her credit. So, I request Madam now to deliver her talk. Thank you. Thank you, Madam. Thank you, everyone. I actually would like to thank the management, Dr. Shekhar Patil, for inviting us to give this talk here. I am overwhelmed by the response. I will just quickly switch over to the talk now. Radiation oncology is a broad band, this thing. He spoke about head to toe. So now we move into specialized cancer, where we talk about each specific cancer and what recently we have done breakthrough in oncology. Gynae oncology is a specialized subspecialty, I would like to say. Though it was a branch of surgical oncology, we gynecologists have a little bit taken over, and we are specialized in our own way. And there have been studies and papers published in American and European both saying that one who gets operated from a gynae oncologist has a better outcome than a surgical oncologist. Similar to whatever in cancer right now in general, where it is going towards more precision, less toxicity, more specificity, gynae oncology is no different. We are also trying to reduce the
toxicity, morbidity of surgery, chemotherapy, or whatever treatments we are giving, and go into more personalized, tailor-made approach to treat these patients. Before going to recent advances, we should know what we are dealing with. This is the Globocon data for 2020 for female cancers in the world, where we can see that the most common cancer now is surpassed by breast. All over the world, breast is the most common cancer, and if you see gynae malignancies, in India actually cervical cancer was the most common cancer, now surpassed by breast. Worldwide data, if you take, cervical cancer is in the 4th position, but in India it is the 2nd most common cancer. The next comes ovarian cancer, which is a more burden to our community because they come in more advanced stages, whereas the Western world are more tortured by uterine cancers. In India, uterine cancers are little early stage, but recently we are seeing an increased higher stage diseases also, maybe because we are treating early stages very earlier or effectively. This is the Indian data extrapolation, where you can see cervical cancer has the highest burden. It is the 2nd most common cancer, and it is actually a sorry state of affairs because WHO has designated cervical cancer as a preventable cancer. To use the word preventable next to a cancer or a prefix for a cancer is a rarity, where I don't think so anybody can prevent cancer, but cervical cancer is a preventable cancer because in 99% of the cases we know the cause. When we know the cause, we can treat the cause. But in coming to from head to toe, all cancers, this is the only cancer where 99% you know the cause, whereas rest of the cancer, 90% you don't know the cause. So this is a preventable cancer, and still we are burdened by it. Maybe about 30, if you take overall Asia, 50% to 58% of the world cervical cancer burden is in our Southeast Asian countries. This is the same National Cancer Registry showing almost following the same figures, though this registry are all extrapolations because most of the rural areas and all, we don't take numbers. It's not documented properly which stage what. This is a rough data collected from the tertiary care centers. Many cases get missed, but overall you can understand it is around the same ratio. So coming to ovarian cancer, I'll just right away dive into each specific cancer and what recent advances we are seeing. Before going to recent advances, we should know that ovarian cancer is the 80% of ovarian cancer comes in stage 3. Only 20% come in stage 1. That is the burden we are facing. That is why this has the highest fatality. Higher the stage, mortality, recurrence rates are also higher. So ovarian cancer is the one where the most of the research basically in immunotherapy or targeted therapy actually took place to find out what more can we do to reduce the death rate or the fatality or increase the cure rate. One more thing about, unique thing about is there is no screening test available. You can't do an ultrasound to predict it. You can't do a CA-125 to predict it. None of the tests have been found to be an effective screening method. So it just comes. I have seen patients having 6 months back normal scan report and they end up in OPD with stage 3 ovarian cancer. Why? Because they grow so fast. The high grade serous cancers grow very fast. So you never know when stage 1, stage 2 comes, they already present in stage 3. And 15 to 20% have family history of breast and ovarian cancer. So that is the one which led to more research into finding targeted therapy. Other risk factors which we know is nulliparity and endometriosis. So never neglect a long-term endometriosis patient. You immediately treat their infertility, give them a child, and we forget about that ovarian endometriosis. No, we should follow them up because in the long term, 1 or 2% can become malignant because some of the patients I'm seeing are all history of all ART, IVF treatment patients who have been neglected after the childbirth, and they end up coming to our OPD with stage 3, stage 4 cancers. this is the mortality rate. If you take 5-year survival rate, if you see, if you detect in stage 1, stage 2, you can give as high as stage 1 is as high as 91%, stage 1A is 98%. Stage 1B or something comes, it comes down to 85%. So stage 1 or 2, you detect up to 80%, you have a 5-year survival rate. But most of the patients are in the stage 3, stage 4 category, whereas the survival rate is very, very low. 5-year survival rate is as low as 30-35%. The standard line of treatment is surgery and chemotherapy. It can be, surgery can be done after chemotherapy, or surgery can be done first and then chemotherapy can be. This is the standard line of management. We used to do surgery, give 6 chemotherapies. Afterwards, we cannot give anything, we didn't have anything else. So we ended up having high number of recurrences. So what were the new developments which we done? In early stage, what new developments came was, in early stage, what do you mean by early stage? Is stage 1A, when it is confined to one ovary. The newer development what we started to do was, we started doing, because they had high survival rate, as high as 95 to 98%, we moved towards fertility sparing surgery in early stage cancers, especially only if they have low grade tumors, stromal tumors, germ cell tumors, borderline tumors. We started conserving their uterus and ovaries, and after their chemotherapy, or once they conceive, have their children, we would go ahead and remove the other ovary and the uterus depending on their age and risk factors. So this was the advancement which we did in early stage tumors. But the problem was in the advanced stage tumors. The standard was cytoreductive surgery. Whatever tumor you see on PET CT, whatever tumor you see visibly, you remove it and then come out. But that was not sufficient. There was lot of invisible microscopic disease which was not amenable to chemotherapy, or where the chemotherapy was not reaching it, and these were dormant in the body for some time, and used to, with favorable environment, it used to come as recurrence, which used to be pretty early for ovarian cancers, as early as 6 months, 8 months or 12 months. So we started now, our focus was on microscopic invisible disease, not detected on PET, not seen to my visible eyes, but somewhere it is hiding. But most of the metastasis was in the peritoneum. So we started doing peritonectomy. Just like how you strip skin, we started stripping peritoneum from all the organs of the body, whichever is feasible. Yes, we cannot strip the retroperitoneum. I cannot strip the peritoneum over the aorta, liver or kidney, but most of it, whichever is possible, we strip the peritoneum, like subdiaphragmatic peritoneum, your parietal peritoneum, pelvic peritoneum, bladder peritoneum. So at the end of the surgery, we started stripping, though morbidity did increase to some extent, but it was manageable in this era of high intensive care. So that was one of the advances. Second one, what we started doing was, we started giving HIPEC. That is, we used to heat the chemotherapy drug and attach it to a similar to a dialysis like machine. That is a HIPEC machine, which used to heat the chemotherapy drug at around 41, and then circulate it within the abdomen after your surgery, so that it would kill intraoperatively how much ever microscopic disease is there. If the temperature comes down, we used to put sensors, it goes back to the machine, reheats and comes. So we used to circulate the drug for 1.5 hours. And other mode also is wherever Dr. Prabhu is an expert in, is PIPAC, where the drug, this HIPEC can be done only intraoperatively. PIPAC can be done at any other time later. You put a laparoscope, you have a pen, which is a capno pen, where it delivers the drug like an aerosol, a chemotherapy drug inside. So it is given inside to deal with the microscopic disease. Basically, all these can be done when you have done a good surgery, when you have removed the bulk of the tumor and you have only some microscopic invisible disease or miliary disease. Miliary disease is where they are in millimeters, basically. So these were the advances in cytoreductive surgery, other than the cytoreductive surgery in ovarian cancer. So next what happened is, still after doing all this also it used to fail. So we have to little bit advance in our chemotherapy also. So after 6 cycles, what we started doing is, we started adding more drugs to maintain this status. So how to find these drugs? That is when this targeted therapy and PARP inhibitors came into picture. what we started to do was they started analyzing the tumor itself. They started studying the tumor itself to see what genetic mutations are there, what pathways are there. Then only your personal therapy starts. Each tumor is different. This same patient, stage 3, grade 3, serous carcinoma, in two different, the tumor may show different range of mutations. So we started doing genetic analysis of that tumor, and whichever more mutation was found in certain patient and the target drugs were available were given to those patients. But standard line what they found when they studied many patients was they found HRR gene defect, that is homologous recombination repair genes. The most common HRR gene is BRCA1 and 2, but there are something like BRCA-like genes, another 15 more genes. They are like, they add BRCA-ness to this. So all these genes are tested, and that testing is called HRD testing. And if they're positive with HRD, see, HRD is not only BRCA1, it includes plus 15 genes. If they're positive for HRD, then there are a lot of good oral medications called PARP inhibitors which are available, which we have shown to increase the progression-free survival, and we are hoping to achieve even overall survival with these use of PARP inhibitors, which is a boon to ovarian cancer patient if they are HRD positive. What I tell patient is, if you are BRCA positive, it is good for the patient but bad for the family. But it is very good for the patient because oral medications, maintenance medications can be given with PARP inhibitors. So that is why how we go about is, first we check in the blood for BRCA1 and 2. It becomes cheaper if we first check there. If they are negative, then we check the tumor again for any somatic mutation, if you can find any of BRCA1, 2 or the rest of the HRR genes, so that our array, the more number of patients can take PARP inhibitors. So what to do if they are BRCA negative, but FDA has allowed even if they are BRCA negative, some response is definitely there, you can give it. Other targeted therapy which we use is something called bevacizumab, that is anti-VEGF. Any tumor has neovascularization, ovary is no different, it's a high grade, high vascular tumor. So we use anti-VEGF drug called bevacizumab, but at the end of the day, it has shown a good PFS, that is progression-free survival by 4 to 6 months, but not more than that. So maintenance we give around 10 to 12, 15 cycles and not more than that. Because it has not yet shown any overall survival benefit. So my good this thing goes only towards PARP inhibitors. So it has been approved in primary cases, recurrent cases also. Other drugs which have recently come is immunotherapy. What is immunotherapy? What is targeted therapy? See, targeted therapy is something like I have evaluated the person's tumor. I found that mutation in that tumor. I will target that gene because that tumor has that gene. I will target that gene. That is a targeted therapy. Like you give your bevacizumab, which is a VEGF antibody, it will go and attack the VEGF there. What is immunotherapy? Immunotherapy is, see, tumor is growing without control in our body. So how is it growing? It is blocking our immune mechanisms in some way. So how is it blocking? So that blocker, if we remove it, probably will enhance our own immune system to fight that disease. That becomes an immunotherapeutic drug. So PD-1, PD-L1 inhibitors or PD-1 inhibitors are the new gang of drugs which are now not only in oncology, it is now approved in many tumors. What this does is, what we do is in the tumor we check for PD-L1. What is PD-1 is, it's programmed cell death cell inhibitor basically. So if that tumor, what does, tumor is very smart. So what it produces something called PD ligand, PDL. PD-L1 goes and gets attached to PD-1 on the T cell and blocks the T cell from attacking it basically. So what we are doing is we go and block those PD-L1. If the tumor has PD-L1, the drug is effective. If the tumor doesn't have PD-L1 and not using that mechanism, so this drug might not be useful. So we check PD-L1 inhibitor in the tumor tissue. If the PD-L1 percentage on the tumor tissue is very high, they are amenable to PD-L1 inhibitors, or directly there are some drugs like PD inhibitors, it will go and unblock the T cell, PD inhibited T cell also. So In ovarian cancer and in many other cancer, the standard PDL1 they are using is Keytruda or pembrolizumab. These are, and medicine is never done without evidence. So these are all the trials which did prove that PARP inhibitors was a good maintenance drug compared to placebo. Coming to, that was our ovarian cancer. We have achieved a very good PFS with PARP inhibitors, and I will still vouch on that. Coming to endometrial cancer, it's a good cancer. I love it because 80% of them come in stage 1, 70 to 80% come in stage 1, grade 1. You just remove the uterus, she is done with it. You need not even lymph node also, you need not remove if it's a low grade tumor. But currently, little bit, we are seeing little higher, or maybe because we are a tertiary center, we are seeing more of stage 3, stage 4 cancers, or because all medical colleges, they are treating stage 1. Why? Because it's very treatable. You remove uterus, it's done. So only advanced cases come to us. These advanced cases are serous variety, clear cell variety, and their survival rate is only 50-60%. Whereas in stage 1, endometrioid grade 1, the survival rate is as high as 98%. So it's one of the good cancers. So here also now we have to improve. What to improve in this? Early stage, surgery itself will suffice. No radiation, no chemotherapy is required unless they have risk factors. So in surgery, what we started to do is, initially we used to remove uterus, lymph nodes, everything. What happened with lymph nodes was, what happened with lymph nodes was more lymph nodes you remove, though it was unnecessary and they were negative lymph nodes, we found to have morbidity like lymphedema, lymphangitis, all those things. So to prevent those side effects, we started to categorize them into, by using genomic profiling. We started here also tumor analysis. Now staging is not done according to standard anatomical staging. We do something called molecular staging in uterine cancers, where we do mutational studies and see whether they are low risk or high risk. Low risk, no extra surgery, no extra adjuvant treatment. High risk, everything is required. Something like that. These are the advances in brief I'm saying. In endometrial cancer, similarly, surgical advance would be, because 80% comes in early stage. Here, to do a fertility preservation is we have to leave behind this diseased uterus back. So what we do here is, in grade 1, less than 50% invasion, early stage tumor, we use Mirena or high dose progesterones for 6 to 9 months, and if most of the time if the tumor is less than 2 to 3 centimeters, it disappears. We maintain it for 3 more months, remove it, ask them to conceive, and once they deliver, we ask them to get the uterus removed, maybe during cesarean or after delivery. So this is one of the things we have achieved, but this also carries a risk of recurrence. What if they don't become pregnant as quickly as possible? You can't use too much of ART also, because endometrial cancers are hormone responsive tumors. So this is a risk where you have to choose your patients for this therapy. Not everyone is suitable candidate for this. Then we started operating 80% are, I told you, are low stage tumors. So it was initially laparoscopic surgery. Now we have gotten into an era of robotic surgery. And the main role of robotic surgery in gynae cancers is endometrial cancers, because the risk factors for C endometrium is obesity, diabetes, hypertension. Most of the patients who come to us are sometimes weighing 140 kg, 150 kg, BMI of 34, 35, and by the time I take a cut, I operate, I do my lymph node, the morbidity is so much, the mortality, by the time our wound heals and I send them for chemotherapy and radiation, they would have finished 2.5 months by the time. So that is not an ideal time to give radiation. So robotic surgery has been a boon to those patients. For thin patients, it probably doesn't matter much, but for obese patients, where most of our patients are obese elderly patients, robotic surgery has a definite advantage. Where what you can boast in robotic is 3D vision. You have a 3D vision. You have 4 robotic arms. All 4 robotic arms are controlled by the surgeon. So you are having basically 4 Actually, one is camera, so you have 3 operating arms. So most of it is surgeon dependent, and the precision of movements, ones who are laparoscopic surgeons here will probably won't like it, but you will appreciate the movements more here, because the range of movements is, it has 7 degrees of motion at the wrist, similar to a wrist. So at the end of the instrument, whatever you have, the operating side, you have range of movements like a wrist, that is 7 degrees of freedom. And that I have a video, I will show it. So obviously, like any minimal invasive surgery, less blood loss, less hospital stay, quicker discharge, and then though it is not here to replace laparoscopy, but it definitely has a place in obese individuals. I don't know whether it will play. See, this is just to demonstrate. Just to show the flexibility of the instruments at the tip, how precisely you can locate one small artery from a branch to clip it. So this range of mobility you will get in robotic surgery basically, but you will probably still need a helping hand, your assistant, who comes through a laparoscopic instrument to clip it here actually. Because at the end of the day you have only 2 working hands, the other hand is fixed, camera is with me, but at the end of the day, so you can see my assistant is coming to clip it basically. I can only little bit guide her. But the precision is good. If you want to do in an obese individual a deeper pelvic surgery, nerve sparing surgery, these are very good tools, because you can see the vision. Actually what you're seeing is a 2D vision. I'll get a 3D better vision. I'll have a depth perception also. And the range of motion in laparoscopy is 1:1. Here it is like 1:3. I move 3 centimeter. Here inside it moves only 1 centimeter. So your tremor and all also is filtered by it. That's basically ligating uterine artery at the origin or at the internal iliac artery. Ureter is just lateral to it, medial to it. You can see the laparoscopic struggle there. Similarly, this is just another video to show how it's easier to suture also. Laparoscopic suturing, you do have a learning curve. Here, robotic suturing, if you're okay with open surgery, you can do the next day itself. This video is to show just the ease of it. Similarly, what we do is in robotic surgery, it has something called a IC, infrared camera. So what we do to avoid lymph node dissection is just before surgery, we inject a ICG dye, and then we see here, and then that glows as green color, the ICG dye glows as green color. We remove those sentinel lymph node. From the OT, we send it for frozen section to see whether it is positive. If your sentinel node is positive, then full lymphadenectomy is done. If your sentinel node is negative, full lymphadenectomy is not done, thereby reducing unnecessary morbidity caused by total lymphadenectomy. And the frozen section also has false positive rate. If they just do a routine histopathology, they can miss some tumor, because we give them only 45 minutes to an hour to tell us whether it's a lymph node is positive or not. So what they do is they do something called ultra staging. They do use IHC markers also to see which is better than conventional histopathology. They will tell us if there are any micromets, if there are any isolated tumor cells, so that we don't wrongly omit lymphadenectomy. At the end of the day, sentinel lymph node has been fully established in breast. It is getting established in endometrial cancers. In other cancers, we are yet to see. Why? Because false negative rates can be there. Wrongly, it might come as negative and we might miss out on positive lymph nodes. So taking that risk into consideration, so we choose the patients, we do it only for early stage cancers and not for late stage. Why? Because in early stage, the percentage of lymph node positivity is very low as 1%. Coming to, I told you in endometrial cancers, staging, no anatomical staging, we do something called molecular profiling. What we do is, we first do a pole mutation. A pole mutation is positive, it's a good tumor, and the risk of recurrence is low, and they are also amenable to chemotherapy. If it's an early stage pole mutation, I might not give adjuvant radiation or chemotherapy. Some risk factors are there. Then next what we do is, we do something called MSI. MSI is done for all tumors now. Specifically to endometrial cancers, if we find MSI positive, it means to say they are amenable to chemotherapy. If they are MSI high, they are amenable to immunotherapy. So if MSI is high, probably if they are in advanced cancers, then immunotherapy will be added. Next we check for P53. Based on this, we put them into 4 categories, that is pole mutated, hypermutated MSI, copy number high and copy number low. If they are P53 mutated, they are very high risk. You have to give chemotherapy basically. So in molecular, as I said, if you have a poly mutation, we de-escalate the therapy. If we have MSI high and if they are advanced cancers, we do add immunotherapy to them. This is proven, as I said, medicine is not given without any trials. So we have trials, Keynote and Garnet trials, where they have tried all these immunotherapy and have achieved a good response rate of 15 to 45% based on the patient's profile. The standard drug which has come now for recurrent is combination of pembrolizumab, that is PD-1 inhibitor, PD-L1 inhibitor, plus lenvatinib, which is a tyrosine kinase inhibitor. And this has been shown irrespective of any molecular profile. It has been shown very beneficial effect even in negative tumors also. And HER2/neu, we used to check only in breast. Now we are checking also in endometrium. If they are HER2/neu positive, we are adding trastuzumab, and it is more common in high-grade serous cancers. Something like this. All are like personalized therapy. We check each patient, each tumor based on their stage, what mutation they have, and what adjuvant treatment. Basically, we are doing tailor-made treatment for each patient here. Coming to cervical cancer. Cervical cancer, I told you it is a preventable cancer, second most common cancer. I don't want to go to recent advances in cervical cancer. I want to go back and do our screening and prevent cervical cancer from coming. I will still stress upon screening along with vaccination. So all sexually active women should start screening once in 3 years if you're doing pap smear, and after 30 years add on HPV testing once in 5 years till 65 years of age. And vaccination, I think, should be a mandate. Now though our Indian version are also available in market, they are saying from January. So I also need to check my pharmacy and see. And also now you have Cervarix. Cervarix is not much available now. You have Gardasil 9, and your Cervavac, which is our Indian make. 2 to 3 doses depending on the age. This is the recommendation guidelines. What advances we have found in cervical cancer is, what extra we have done is, early stage 1, we have to do surgery. Once it goes beyond stage 1, no role of surgery unless in palliative setting or exenteration procedures. We give radiation and chemotherapy. In surgery, what we have advanced is, we are trying to, with the advance of minimal invasive surgery, we are isolating the nerves and sparing the nerves, which we were taking out in the radical hysterectomy along with the parametrium. We used to take out all the autonomic nerves supplying the bladder, rectum. So they used to have a lot of problems with sexual intercourse, your bladder function, bowel function. So now, because of minimal invasive surgery and even open surgery also now, if you do it with lot of patience, we can actually isolate these nerves, put it little separately, and we can take the parametrium. So at the end of the day, this is only for stage 1. Stage 2, stage 3, stage 4, what to do? Again, comes to again your personalized tailor make, where the novel therapeutics are the targeted therapy and immunotherapy, and the recent FDA approved drug for this is pembrolizumab or Keytruda, that is PD-L1 inhibitor. We do the tumor testing, especially in recurrent setting. Now they have approved it for primary setting also, along with chemotherapy. See, standard drugs you have to give, these will be add-ons basically, because it will never replace the standard chemotherapy. If you think immunotherapy has done wonders, yes, it has done wonders, but it is not equivalent to the standard chemotherapy or standard line of regime you are giving. Your standard line of regime should follow. This will be add-ons. But at recurrent setting, when all chemotherapies are learned, maybe then they become single agent treatments. But standard initially when we treat them, these will be add-ons. And now Keytruda is approved for upfront treatment along with Paclicarbo. Paclicarbo is a standard chemo which we give for CS cervix. So along with that, other drug which have been approved is bevacizumab, same targeted therapy, because all tumors have neovascularization. If you prevent neovascularization, that is anti-VEGF factor bevacizumab, and it is approved in actually in recurrent setting, basically recurrent resistant settings. But at the end of the day, you can individualize and treat the patients. If they're not responding to standard, you can switch over to these things. And these are the main brief. Vulva, vagina, I would not want to take. These are rare cancers. So the precision is basically improving your surgical skill to reduce morbidity, and tailor-made treatment based on genomic profiling. The message across is the same, only thing is specifically it might change a little bit depending on the organ. Thank you.
Thank you, ma'am, for educating us on recent advances in gynecological cancers. Any questions?
That was an excellent talk by Madam. I would just ask one question, Madam, regarding the HPV vaccination. So, how is your experience with that?
Ma'am, we are vaccinating everybody who comes to our OPD. So 9 to 45 years it's approved, though it is best effective if you give them before they are sexually active, within 9 to 15 years, but we are not getting them. Those are not the population who come to us. That's why we are telling pediatricians to give it. But in spite of that, patients are coming to us, their relatives. I have treated a cervical cancer or any other cancer patient, their relatives. I tell, if you are unmarried, it's best you take. Even if you are married, out of the box, I am treating my CS cervix patients also. Why? Because I treat a CS cervix patient, I am eradicating the disease. I am not eradicating the virus. The virus is still there. It can cause vaginal CA, vulval CA, anal CA, HPV can cause pharyngeal CA. Husband also is there. So I tell husbands also, you also take vaccine. It's approved across 9 to 45 years. In India, nobody talks about it. Nobody tells men to take, but actually men should take. It's a sexually transmitted virus. So because it causes all other cancers, I tell my patients also after a certain period, if they are 1 year, they are all right, I tell them maybe it will be effective to fight against vein 1, win 1, so win 3. So I tell them to take. So if I'm telling my cancer patients itself to take, other people I tell them some benefit is better than not having anything. But vaccination doesn't replace screening. I tell them please continue screening, but take vaccination, it's an add-on immune booster. I am giving, ma'am, I am giving to everybody. And I have not found, because I used to give more Cervarix, but from after COVID, Cervarix availability is reduced. So I am now giving Gardasil 10 basically.
Thank you, madam.
Excuse me, madam.
Yes, sir.
You told of the intraoperative aerosol therapy.
Yes, sir.
One second.
Sir, Servavax, sir, Indian make vaccine. I think it is released in January, sir.
The Government of India yesterday's budget for the women, Nirmala Sitharaman has announced it will be free from 19 years to the 40 years, whatever they have announced.
Good, sir. It should be, sir. Yes, sir.
In intraoperative aerosol therapy, are you using conventional formulation or using nano formulation?
Sir, conventional formulation, sir.
Conventional.
Not PIPAC, sir. PIPAC is not done intraoperatively. HIPEC we do intraoperatively. PIPAC means if open, no, sir, there is no aerosol pressure. So we do it at a later setting where we put through a laparoscope, sir. He is specialized in peritoneal.
And suppose, for example, the first stage cervical cancer is detected. Do you still advise, in that case, the patient takes HP
So 99
vaccine. No, vaccine. After detection, right? It is detection of vaccine. Does it this one modulate the course of further?
No, sir. No. Actually, there is no benefit theoretically speaking, sir.
So once a disease
because the disease has already come. The virus is attacked. So it doesn't matter. But I give it with conviction that I have not eradicated HPV from the genital system. It causes anogenital cancer, penile cancer, anal cancer, vaginal cancer, vulval cancer. Maybe I will reduce that risk by vaccinating them so that it will help her fight immunity.
Thank you.
Yes. It's an unconventional way, not a standard way. I am using it. Yes, sir.
Broader classification of ovarian cancers.
Yes, sir.
You told that PDL1 inhibitor
Yes,
you
sir.
are using and chemotherapy, madam. In which cancers most in your hospital will get that? Which
drug, sir? Sir, I told no, sir, you should not deviate from standard line of treatment. Standard line of treatment for ovarian cancer is surgery, surgery and surgery for macroscopic disease. For invisible disease, you need chemotherapy, but only when it is inoperable. Most of the, what we do is initially we give 2-3 cycles of chemotherapy, reduce the tumor burden, so that less I operate, less morbidity I give to the patient. Then I go in and remove as much as possible wherever, not as much as you're supposed to remove nil disease, nil visible disease, remove all visible disease. We call it R0 resection, where no visible disease is there. So you remove everything and then give again microscopic disease is there, sir. It is not seen to me. I won't know what to remove. That time only we are doing HIPEC therapy or peritonectomy. Though we are not seeing the tumor, peritoneal metastasis is the one which recurs, sir. They always fail in abdomen only. Ovarian cancer fail only because they will have peritoneal recurrence only. So by seeing it, we are removing the peritoneum. But the problem is we can't remove every peritoneum. There will be a peritoneum on the sensitive organs. We can't strip it, sir. So how much ever peritoneum will do, rest of the disease, if HIPEC is done, it will kill those cells. Because we are...
In all types of ovarian cancer.
Advanced cancer, sir, 80% of which are advanced. In stage 1, stage 2, we don't do HIPEC, sir. And we give standard Taxol carbo and bevacizumab if they are HRD negative. If they are HRD positive, Taxol carbo Then we will followed by PARP inhibitors, sir. PARP inhibitors can be given 2 years, 5 years. Right now, I think approved for 2 years, sir. Based on the toxicity, cost factor, everything will come into picture. It also has risk of leukemia if overtaken over long term.
Okay, thank you, madam.
Rest of the questions will be answered later. I request the chairperson to kindly present certificate of participation to the guest speaker. The chairperson will receive the certificate from Dr. Raghavendra Gopur, Professor, Department of Pediatrics.
Thank you, ma'am. It is my honor to invite Dr. Manjunath Kotanavar, Head of Department of Surgery, to chair the session on multimodal approach in cancer surgery, converting the inoperable to operable, which will be delivered by our next guest, Dr. Prabhu N. Nisargikar.
Good afternoon to one and all. I thank the organizing committee, the Department of Medicine and SRS for giving me this opportunity to chair the session. Students, do you know which is the thrilling and most rewarding part of oncology treatment? It is always surgical treatment, oncosurgery. So here today we have here a dynamic surgeon, Dr. Prabhu Nesargikar, who is going to talk on multimodal approach in the cancer surgery, converting the inoperable to operable. I feel honored to introduce Dr. Prabhu Nesargikar, who is qualified with MRCS, MA in medical education, MD in research. He is a highly experienced surgical oncologist with expertise in bariatric surgery as well, with surgical gastroenterology and advanced endoscopic surgery. He is a consultant GI and peritoneal cancer surgeon, bariatric surgeon and surgical gastroenterologist at HCG Cancer Hospital, Bengaluru. Dr. Prabhu is one of the select few surgeons who offer a comprehensive approach to gastrointestinal cancers like CA, esophagus, stomach, intestine, etc. From organ preserving endoscopic surgery to minimally invasive surgeries, both laparoscopic as well as robotic. He is experienced in peritoneal cancer treatment including PIPAC and HIPAC. He is also well versed in bariatric surgery and other comprehensive weight loss treatments including intragastric balloons, etc. And he has, to his credit, n number of publications in international journals. He is the recipient of several awards of accolades including the prestigious Young Investigator Award at ESOT Congress, Belgium. Then he had topped the national interview in United Kingdom to enter the highest specialist training in NHS. And he has awarded MD for his research from Cardiff University, UK. He has awarded MA degree in medical education from Kiel University, UK. So here I present Dr. Prabhu Nesargikar to the audience. Over to you, sir.
Thank you very much. Namaskara. This is my first visit to Vijayapura. Looking at the warmth and hospitality, I think I should make more trips more often. So in my title side, I put both BLDE and HCG. I think it's a very good collaboration going forward. And as I said, thank you for the kind introduction. So compared to as my previous speakers are speaking about the Western world, I am from the Western world, completely trained there, and now I come back to India after a long time. I also practice in Singapore as a consultant, but now I lead the GI and peritoneal cancer work at HCG Bangalore. Another thing is all about preventive oncology, which is close to me, so I'll talk to you about the end. Dr. Jairam also highlighted about that. So this is my main practice, mostly GI and peritoneal cancer work and robotic surgery. These are already highlighted before. So just to give our audience a brief overview of what HCG is about. So we are a 26 cancer center chain across India and now also expanding across the other continents as well. So we are the only corporate IPO oncology based chain hospital in India because most are multi-speciality. So we eat and drink cancer every day. That's the language we speak. So that's the language we want to communicate with BLDE going forward as well. So as you see, we have lots of verticals in a cancer care. So gone are the days was only one department controlling everything. So now we have all subspecialization from surgical to hematology to interventional radiology. And most important, I would suggest, is the allied specialties to make the cancer outcome successful. So we have nutrition, yoga and physiotherapy, and psycho-oncology. Now these things have a significant impact, and I'll show you some evidence also going forward regarding that. Lastly, just brief about our academic research. As I said, I was very impressed with the setup you have here, which is dedicated to teaching and training and research. We also believe in that motto, so we have multiple associations with other universities worldwide, with the whole aim being exchange of knowledge makes us grow better, and cancer is an ever-evolving field, so we are never experts in that field until the end of the journey. So we have a few fellowships, so any students who are interested to come to HCG for joining and then come back to BLDE to practice the same, you're very much welcome. How I've structured today's talk is in 4 parts. I'll limit my time accordingly. So one is the incidence of GI cancer, how we are changing landscapes in GI cancer. So I'll show you some case snippets, how we have changed, how do we changing lives in their outcomes, and lastly about preventive oncology. Now, as you know, the rise of GI cancer is now a global phenomenon. Obviously now more it's picked up more commonly. So if now you see the colorectal, the stomach cancers are coming into predominance, both in the Western world and the Indian world. And GI cancer carries a lot of morbidity and mortality. So if you don't treat it right the first time, you'll end up burning your fingers, and because the mortality is really high, especially esophageal cancers. Now this is a slide I found in India. So when I first came to India and I moved back, I said, what are the common cancers in India? This is the only slide I could find. So if you look in South India, head and neck and GI cancers are very common, whereas in North, the liver cancers are more common. So why is GI cancer and surgery important? Because that's the cornerstone for achieving cure. So how we've spoken in gynae, where surgery is the cornerstone, same in GI cancer as well. But we have moved away from saying it's the surgeon who is the cure, but actually chemotherapy and radiotherapy form a very important part of our team because they help us downstage the disease. Now MIS surgery, as highlighted, including robotic, has very good outcomes. So in our operation, everything is MIS as a start. We don't do open surgeries. The index is put a laparoscopy and then we see, or put a robo and then see. So what I'm going to do is I'm just going to show you some 5 or 6 cases we have encountered in the last 4 years I've been in HCG, how it was considered palliative, and what we did to make it as a curative intent. So case 1, this is a lady from, I think, Mangalore. She was 74-year-old with 2016, was diagnosed with upper esophageal cancer. So according to protocol, she underwent definitive RT and chemo. And then in 6 years down the line, she now recurred with a stricture 24 centimeter. So she went to a peripheral hospital where they said, okay, look, you're 74, you've got recurrent cancer, we can't do anything for you, we'll make you palliative. So they gave her brachytherapy and chemotherapy instead in February 2023. Then she came to us, me and Patil saw her together. So she had an NG tube feeding in for the last 3 months and she was quite desperate. She said, look, I have an NG tube, I don't have a life, what can you do? So we had no other options of neoadjuvant treatment. So we said, why don't you go for robotic esophagectomy and try if this helps? So this is what Dr. Abhilash was also highlighting, how robotic surgery helps. Now this is an edited video where you can see. So the patient is lying prone, so the heart is on the bottom, and this is the advantage. So now, if you can see, now we are coming to the danger territory of the esophageal surgery. So all the radiation is the fibrosis of the white band, and that's the esophagus. Below is the airway pipe. So in laparoscopy, you will not be able to differentiate where the esophagus starts and how it attaches to the airway pipe below. So with very gentle dissection, again, it's a team approach. It's just not me. There's other consultant surgeons involved in the surgery as well. So safely, we were able to negotiate the esophagus from the airway. Because if the airway gets damaged, the mortality rate really doubles or triples. So in this patient, we were able to do the esophagectomy. This is the specimen which came out. So we had a ERAS protocol. Most of our esophagus patients stay only for 1 day in ICU, 7 days in the ward. Look at a pathology. From a patient who was considered palliative, she ended up being a T3 and not staging. So she dropped down the staging. Now she's undergoing chemotherapy, and at 6 months, she has got no recurrence. So this again highlights that not everything is palliative in surgical world. If you have a good team to discuss and manage accordingly, you can still give them reasonable good outcomes. So this is the robotic surgery which Dr. Abhilash was highlighting. This is a surgery I just did day before with my team. So this is how robotic setup looks in theatre. So this is where the assistant sitting there. So you can see we are doing a colorectal surgery with robotic. This is how the Da Vinci system we have in our theatre. So for going forward, I would encourage BLD to get a robotic system as well, because it's a wonderful platform for training surgeons. Because I can move out, somebody else can come in. So if you can, this is the layout of how the robotic surgery works. So through all the arms, my assistant is working there. And as you go down, so I'm working on the console at the end. So look, I'm unscrubbed. So if I'm in trouble, I can get my colleagues to come. So this I'm showing you now the next case, how a multidisciplinary approach in robotic surgery can actually have better outcomes as well. Now, robotic surgery, now evidence is coming that actually it is much more better than even laparoscopic surgery to achieve certain outcomes. So in esophagectomies, the opinion is still out in the public. But going forward, I think in the next few years, you'll see most patients going for robotic surgery and most surgeons preferring robotic surgery as a primary option. Again, a second patient, this patient actually is from Miraj. So he was a patient from North Karnataka. He had a mid-esophageal cancer. And this is why MDT is very important. He went to local hospital where they recommended upfront surgery for him and not chemo-RT. So they did a big thoracotomy and they said, your tumor is adherent to the left bronchus, it can't be removed, so they abandoned the surgery. So said nothing can be done, so he came to us then. So me and Dr. Shekhar Patil, Dr. Lohited, we had a discussion. We said, why don't we treat as a primary cancer and ignore the surgery? So we said we'll give a cross protocol. So he went for chemo-RT with a curative intent. Now that day we had a robonode, obviously we did a laparoscopic surgery. Again, as you can see, the previous surgical site, our worry was in this area on the top, where the airway is on the bottom. So for students, the white pipe you can see on the bottom is the main trachea. So that can't be injured. On the previous side comes the left trachea. Now they had abandoned this because it was adherent to the left bronchus, but we, with gentle mobilization, were able to peel away the esophagus away. That's a specimen on the right. But look at the final pathology of what the patient got. He had a TXN0, which means a complete response to CT-RT. So again, I'm stressing again. So in esophagus, surgery comes second. But if you're able to downstage the disease, so now this guy is cured because his TXN0, his rate of recurrence is very, very low. So that's the main highlighting point. So I just moved on organs because I do esophagus and gastric and colon. So it's again a snippet of a third cancer. She's a 74 lady. So she's 74. Gastric cancer showed adenocarcinoma. Now if you look at the laparoscopy picture, that is what the linitis plastica picture looks. Stomach looks very dense, infiltrative. Unfortunately, she had some white nodules on the bottom picture, which means she had a local spread. Now in the Western world where I come from, if you had a small node there, it is palliative. It's called M1 disease. But when I was in Singapore, we pushed the boundaries. So both the Japanese and the Koreans and all those, now we're pushing because gastric cancer is very high in this part of the world. So we said, why don't we treat it along with the primary cancer? So this lady said, again, MDT discussion, we went for a flawed chemotherapy. She had a genomic report. It showed low-dose immunotherapy. And this is where PIPAC surgery came into the picture. So very few cases. So what is PIPAC? I'll just quickly show you. So this is a pressurized intraperitoneal aerosolized chemotherapy. So this is where so you only put 2 ports in. That is the pen which converts the liquid chemotherapy. So in this patient, we use cisplatin doxorubicin. So conventional chemotherapy drugs. So this liquid is converted to air. Now this machine, this Capno pen is very expensive, but now the price has come down. But what this does is, in this patient, we said, if I give PIPAC, she still can have the chemotherapy the same day or the next day. But we are treating the peritoneum in the same sitting. We're not ignoring it. So this patient, look at this. So she basically had a chemotherapy started. We gave her 1 PIPAC dose, repeated the PIPAC at the second dose. Second PIPAC, we didn't see any new peritoneal nodules. So it shows we're actually downstaging and controlling the spread of the disease. Now she underwent surgery now 1 month ago, where she had developed 3 more nodules, but she still underwent a CRS, gastrectomy and HIPEX surgery, which again is an achievement because most of these patients would not even end up having the primary surgery. Now, PIPAC, as I said, has been in for the last 10 years. We got trained in Singapore, which was the first center in Asia to do it. So PIPAC is a very simple procedure which can be done for patients with peritoneal mets. So it can be for ovarian, colorectal, gastric, pancreatic cancer. But now slowly PIPAC is moving into the neoadjuvant setting. T4 gastric cancer tumors where you know there's a high risk of peritoneal disease, we possibly will use PIPAC as part of a neoadjuvant setting as well. So this is the ESMO guidelines. So as we said, we follow standard chemotherapy protocols, but immunotherapy is now coming more into the picture of neoadjuvant setting as well. So most gastric cancers all go for chemotherapy unless they're very early stage disease, then we go for upfront surgery. So again, the same snippet, this lady is from Cuttack. So she had a similar history where she had a gastric cancer with a proven peritoneal metastasis. So PCI score is 6. So we do peritoneal scoring scale, and that determines how bad or good the disease is. So again, she was not given much hope. She was given chemotherapy for 1 year, then she came to us. So we said, actually, you'd not do bad. We'll do a laparoscopy and then go. And we said, this lady, we planned for a CRS and HIPEC. So because she had a low PCI score, what we call, she was able to undergo this. So as Abhilash was highlighting, this is how a post-CRS surgery looks like. So this patient obviously had a couple of liver nodules which came negative. On the left, you can see all the peritoneum stripping images. This is how it looks post-CRS surgery. So that is the bare abdominal wall muscle on the lateral side. She had some small nodules on the small bowel which proved to be negative. So we see we completely take out the peritoneum from all angles. As you go down, this is the pelvic side as well. This is near the porta hepatis, near the liver. So anywhere we can see macroscopic disease, we try to achieve what is called CCR0. So in this patient of gastrectomy, again, few years ago would be palliative. So we did this, and this is what HIPAC looks like. So this is HIPAC on the right. So this is as Abhilasha is highlighting. It's hot chemotherapy, 42 degrees centigrade, 30 to 60 or 90 minutes based. Conventional drugs are used. And this is how HIPAC is given for 60 minutes. Now what happened to her? So if you can look at this, let me go next slide. So she had a 7-day ward stay, went home without any issues. We also put her neoadjuvant IP chemotherapy. At 9-month follow-up, she has no recurrence on PET CT. From somebody saying, so we have told her, her disease is going to come back. But can we increase the DFS? Because that actually will help her. So 9-month follow-up, she has no recurrence. She's still on immunotherapy and she's doing very well. So what do we know about gastric cancer petrol metastasis? Very commonly seen, I think from North Karnataka, I've seen almost 2/3 patients who come very advanced, because in our community or patients don't come very early on because they think nothing can happen to them. So I encourage them. So in the last 1 year, we've done almost 4 cases. Both have done well. But it is a very aggressive disease and it should be done. So if you look at the trials happening across the world, so in gastric cancer, there are lots of trials looking at, can we include PIPAC surgery or any chemotherapy upfront to downstage the disease for a surgical resection. So this is again a very good case. I'm going down completely down the order to the colorectal cancer. Again, this is from a very famous institute in Bangalore. There's a patient who was 65 years old, colorectal cancer in 2021. PET CT T3N1, so technically surgically operable. He had chemotherapy in RT as a standard. But somehow in the middle of the way, they said they gave him a segment loop colostomy and had multiple chemotherapy, and they said surgery cannot be done now. The reason being, if you look at the PET CT, he had a colorectal cancer invading into the prostate, and they said, look, nothing can be done. And this is where the beauty of the robotic surgery comes, because we were 3 teams operating on him, our team, my GI surgical team, and also the urology team, because we are sub-organ specific. So you see this completely plastered, you're taking out. Now there's a urologist came. That's your ureter being cut with the catheter being seen. So we did the rectal part. Now they removed the prostate. They're suturing back the ureter again. So with one console, one surgery, same docking arms, you're able to do a complete APR, removes prostate, and do a wide perineal local excision, including the extended lymph nodes. So if you look at how the specimen, this is how it looks at the end. So from a person who could not be operated upon, now we have gone and given him a CCR0, complete clearance on the bottom. So we took some plastic surgery help to flap this across. So now you see 6 months follow-up, he has no recurrence. So again, the patient who was told nothing can be done. So we have achieved as a MDT team to achieve this. So the last of my case snippet, again, very common, you may see here is a colon cancer with liver mets. There's a guy from Bangladesh, he came looking for us. He had a right colon cancer with 4 liver mets, as seen upon the PET CT, but a big node around the middle colic vein. They told it was inoperable because of liver met and the node bulk. And again, he came as a palliative. Here we had almost 4 surgeons operating, me, myself, another colleague, a HPB team. We did a right hemicolectomy, liver metasectomy. We did a microwave for a deep lesion, adjuvant chemotherapy for 6 months. 2-year follow-up, he has got no recurrence. Even now when I go to Dhaka for my clinics, he still comes and sees me because he says, this is something we could do. And again, I'll highlight to him, it's not my approach or our approach, it's a team approach which led to this. One more thing I would just like to, I don't know if people have heard about oncobariatric surgery, which is coming up in literature. When Abhilasha was saying that most of our patients, women who come with breast or endometrial cancer, obesity is the #1 cause of cancer, not BRCA. So in these patients, actually, we have done few cases now. We in Singapore we're doing. So we've done combined hysterectomy and sleeve gastrectomy as a bariatric procedure, or done something to make them lose weight. So to lose weight in a controlled manner, cancer patients actually is beneficial to them. On the contrary, we all think cancer cachexia is there, so we should be nutritionally well fit. But quality food with weight loss in obese patients actually helps them in the long-term run. So I'm just going to show you a couple of outcomes we've had in the last few years since I've been in HCG. So we do roughly around 100 cases of upper GI and almost 120 cases of colorectal surgery. All our upper GI cases, majority go for chemo-RT. Luckily, we have had no leak, no peri-op mortality, and the same exists for our cases in colorectal as well. We have a very, very low stoma output. So we are doing actually one of the world's best. We are now compiling all the data because we've had no leaks or no mortality for last 3 years. So now I say, okay, why are we getting such good results? Is it because we have some blessings of a God or some lucky charm? But I say it's a team effort. So whenever you're building teams in cancer work, please build a team, because oncosurgery is a team effort. So even in Royal College England, it's always about the high performing surgical team, not the surgeon. So once you have a good team, then this is all the components of the team. So we have a surgical team, anesthetic team, the OT team, healthcare team, medical. So we all sit and discuss as to how we can achieve the best outcomes for the patient who come through the door. As I said, for good outcomes, three main things. One is the patient workup, the team verticals were covered, and prehabilitation. And I said, so hopefully I think most of the cancer centers follow this. Make sure you do the right treatment the first time. Please review the pathology slides. We have surprises where a patient was called adenocarcinoma. He came to us, we got Burkitt's lymphoma. Patient went from being, he was a minister's PA, he went from being operation to just chemotherapy. Have a good MDT discussion with your medical oncologist and radiation oncologist. And please include the patient family discussion at the end. Because medical legally as well, they have the choice to choose what they want to go ahead. One thing I want to highlight was prehabilitation. This is very much of a Western concept, but very quickly picking up in the Indian context. So what is prehabilitation? Is process of improving the functional capability of a patient prior to a surgical procedure. So Jairam was highlighting in the morning about the lifestyle choices and all. So each patient who comes to the door, there is a patient who there's a dietetic counseling, there's a physio counseling, and also a lifestyle modification. Now we look at the literature, it is now abundant now. Everybody who's been to the prehabilitation program, your surgical outcomes magically get better because you're preparing them. So I tell my patient, like gallbladder hernia is a T20 game, cancer surgery is a test match. All cricketers come 3 days before to the test venue. It's not like they're flying on the day. Same is cancer surgery. So any patient who comes to the clinic, you start working from day one, not just 1 week before the surgery happens. So what's the benefit of prehabilitation? It improves the physical performance and nutrition status. It reduces the length of stay. Your post-op complication comes down, improved quality of life, and reduction in stress and risk of depression. One more thing I'm highlighting is the surgical oncology organ specific. So the Western world is on organ basis. So in HCG in Bangalore, we have the similar protocols. I'm only a GI surgeon, HCB is separate, head and neck is separate. Now it's getting so specialized, even the medical oncologist is organ specific and radiation oncologist is breast specific. So in 10 years down the line, a breast cancer patient will be seen by a breast surgeon, a breast radiologist, radiation oncologist, and everybody else. So going forward, organ specific is going to be the future. So we should start preparing from now itself. This is the last topic, is for all of you. So even if you're not interested in cancer surgery, preventive oncology is the one where the future lies. Now this is a famous slide I used from my UK website. So if you look at how many cancers can be prevented, they have literally mapped all the most common cancers. So on the left is all the causes of cancer. On the right, so example, if you look at lung cancer, tobacco is the highest risk. You look at bowel cancer, red meat, overweight, all these components come. So we traditionally know that tobacco was a very common cause of cancer, but you'll be surprised to know the most commonest cause of cancer worldwide is obesity. You're overweight, your risk of cancer increases. I show in my next data. So this is again a slide we use for breast cancer patients in UK and in India on all my talks. So if you can see, overweight increases risk of cancer by 7 times in women. So look at the right side. So if you're a healthy weight, only 194 women get cancer. But as you become more overweight, there's a 41% whopping increase in cancer risk in your case. So women, if you're at a risk of breast and ovarian endometrial cancer simply because of obesity. So simple lifestyle modification to lose weight is very good. So I would encourage BLDE to open a preventive oncology clinic in that aspect, because what it does. So look at when I first came, I looked at the screening programs. In UK, we have 3 standard screening programs: bowel, breast, and cervical. In India, there is no screening program. The government launched a paper in 2016 to say we should do oral cancer and cervical cancer, but we still don't do any screenings for them. So now we have an opportunity to make sure that we can look at patients early. So this is the top cancers in India, again from database. Women is obviously breast common, men oral cavity is more common. Now all this can be picked up by simple screening tests. So clinical examinations or blood tests, only PSA is the only FDA approved blood test, not CA125, not CEA. Ultrasound scans, so for even ovary cancer, if they have a routine ultrasonography once a year, why not? You can pick up an ovarian cancer if it is there. Endoscopy and pap smear, depending on what we find. So in Bangalore, we launched the MRI whole body screening program. So this is for patients who just walk in to say, look, I just want to be screened for any healthy this thing. So they go to the MRI whole body, not CT scan because of radiation exposure. And we have done 100 in the last 2 years. We have picked up a couple of prostate cancers on patients who were not asymptomatic. So again, screening programs, please look at your local geographical database, what do you get? And please design the screening programs accordingly. And the reason is this. early detection of cancer leads to faster and effective cure. So look at the top one, which is the breast cancer. If you have stage 1 breast cancer, your survival up to 5 is almost 100%. But moment you start dropping the stages, your survival drops. So same is for stomach, same is for colon, for liver as well. So stage 1, everybody does very well. So if you happen to pick up a stage 1 breast cancer or stage 1 stomach cancer, they actually can live longer. So we encourage patients to come and report symptoms, listen to your body. As Jairam was also, we were sharing joke, when you get your car serviced, get your body serviced. So similar concept, simple radiology test like ultrasonography, MRI can pick up cancers early. So please kindly look into opening a separate department for that, because that I think where the future lies. So to conclude, outcomes from cancer surgery improving over the decades. Prehabilitation ERAS protocols in cancer patients improves outcomes. Organ-specific surgery will refine and define surgical approaches in cancer going forward. And lastly, preventive oncology, you all have a role. Because by preventive oncology, you make cancer as a common word of talk. It is destigmatized. If you look at your own relatives who had cancers in the family, they never told anybody. They only came at stage 4. But if they knew that cancer was curable, they would come possibly much more earlier. So that's the last thing. So thank you very much. I think it was a very pleasurable interactions. Hopefully you've taken some points from this. Thank you.
Thank you, sir, for enlightening us about the multidisciplinary approach to help us to treat the cancer and introducing out to newer techniques like HIPEC. Now, I request the chairperson to kindly present certificate of participation to the guest speaker.
A few words. I thank you, Dr. Prabhu, for his excellent presentation, wonderful presentation, and for his even excellent results, with his experience with excellent results. All these days, we general surgeons, we had a concept of palliative surgery in mainly advanced GI malignancies like CSOPS and CS stomach. He has made us realize that even in advanced CSOPS and CS stomach, surgery can be done with a curative intent. Thank you, Dr. Prabhu, sir. Any questions from the audience?
One is the ethos to do that we're going to build that. Secondly, you can have preventive oncology physicians or doctors who can think to this concept, and mainly is test-based. So mammography, pap smears, and you have a clinic to say we can prevent cancer. I think that will be the highest OPD you will have, because as you can do vaccination for hepatitis B and cervical cancer, pap smears in all reproductive age group women, mammography screening. So I would say you do 100 mammography screening, you'll find 5 breast cancer patients, and that's why when you start up, then it all starts expanding. And I think that is a good, if you have the model intact and the examinations ready, then I think it'll be very nice to start off with. And I think you have a vision to do that. So I would encourage to have that. It'll be the first in North Karnataka to have a preventive oncology clinic, where everything is covered, including vaccinations, screening tests, and all literature to discuss that. Look, if you stage 1, you get cured. So the word goes around. So my own idea is to destigmatize cancer. My own relatives did not come to cancer till stage 4. But we know that you come at stage 1, you get cured. So the whole thing is spread the word, the people will come. That's the main idea.
Thank you, Dr. Prabhu, for emphasizing on preventive oncology too. You know, the screening test for many of the malignancies can be done with a good intention from the government sector. It has to be done free of cost, or at least in a subsidized rates. Then only this preventive oncology concept works good. Okay. Thank you, Dr. Prabhu.
I request the chairperson to kindly present certificate of participation to the guest speaker. The chairperson will receive the certificate from Dr. Sumangala Patil, Vice Principal of Pre and Paraclinical.
Thank you, sir. It is my honor to invite Dr. Sureka Hipparigi, Head of the Department of Pathology, to chair the session on recent advances in hemato-oncology and introduce our guest speaker, Dr. Nataraj K.S. I hand over the proceedings to Chairman.
Good afternoon, all. At the onset, I want to thank organizers and SARS organizers and respected Sir Dr. R.C. Bidri, sir, for giving me an opportunity to chair the session. I have got a great honor to introduce Dr. Nataraj K.S., who is a senior consultant, hemato-oncology and stem cell transplantation. Sir has been celebrated as a hemato-oncologist and BMT physician practicing at HCG's Cancer Center, Bangalore. I am very much excited. We are with such a person, all of us, with such a person who has performed more than 1,500 stem cell transplantation. Big applause to Sir. Sir also excels at treating hematological malignancies, leukemia, lymphomas, aplastic anemia, myelodysplastic syndromes, and myeloma, and other blood-related disorders in both pediatric and adult patients. Before HCG, he was associated with prestigious healthcare institutes like Muzamdar Shah Cancer Center, Sri Shankara Cancer Hospital Research Center, and Narayana Hrudayalaya. Sir has been graduated in MBBS and MD Internal Medicine, DM in Hematology, Hemato-Oncology and Bone Marrow Transplantation. He has been a EBMT Certified Transplant Physician, FRCP, Glasgow. Sir has been an expert with his team, that is CAR T cell therapy, expert in treating post-transplant complication, post-cancer therapy management. Not only he is a physician, great physician, but he is also involved as a researcher. He has been an investigator in leukemia, lymphoma, aplastic anemia, and multiple myeloma projects. He has been an academician in guiding hematology fellow persons. Sir has played an instrumental role in setting up the stem cell transplant center at Sri Shankara Cancer Hospital. He is also responsible for multiple protocols like autologous and allogenic, matched, unrelated donor, mismatched, etc. stem cell transplant programs. He has also been collaborated with the industry leader for clinical trial and CAR T cell therapy. Sir has been not only a great physician and academician. In spite of his busy schedule, he has got involved in rural health checkup camps and pulse polio immunization programs, and he's also been trained in cell gene therapy division at the Houston Methodist Hospital, Baylor College of Medicine. He has got he has got involved in multiple award and the institutes and medical association like American Society of Hematology, American Society of Clinical Oncology, Indian Society for Hematology and Transfusion Medicine, and International Society for Cellular Therapy, etc. He has been invited as a speaker for multiple national and international level conferences. He has been throughout, he is very good in academics and several gold medals in throughout academic careers. He was a best outgoing students award also he had got. Sir has got a multiple presentation and in various level, national level conferences. He has been authored chapter in certain books and of hematology reflects his in-depth knowledge. Sir, Dr. Nataraj sir also boasts a distinguished publication record with a numerous paper published in prestigious national and international journal. Here I present Dr. Nataraj K.S., a multifaceted person, and we are blessed to have him sir. We have you, sir, here for today's event. Sir is going to deal with the recent advances hemato-oncology. Over to you, sir.
Madam, thank you for warm welcome and then the great hospitality I had here. I will go ahead with little bit of recent advances in hematological malignancies. I can tell you that it is 10 times more exciting than any surgeon what they do. So you can see here it will be a visual treat. I know all of you are hungry for food, but I cannot give you a food treat, but I can definitely give you a visual treat. You will enjoy it. So I think all these years cancer department used to be an oncologist. Now I think in the era in the future is going to be not a cancer oncologist, it's going to be an onco-immunologist or immuno-oncologist in other way around. So it is one, we have to ensure that we empower body's own system to kill the cancer, or we empower alter some of the cells so that they can go and kill the cancer cells. So it's not going to be like anybody, like America bombing Afghanistan. I think that's not going to have any good outcome. People have bombed quite a lot, and I think all of us know that nothing has helped in any way, bombing America. I think how the targeted attacks, drone attacks, is what the future, even in the cancer care, that is how it is. So I will have little bit discussion about what is cancer immunity and how cancer evades immunity and what are the ways that we can get over from it. So what is cancer? Cancer is basically, it happens because of repeated injuries leading to inflammation and then leading to sort of mutations in the body's cells, and then ultimately leading to changes in cell and also the surrounding cell. So it is like nobody gets spoiled if your company is all right. If your company is not wrong, then only people will get spoiled. So the company's immune system, the cells are cancer cells. So it is usually both are abnormal. So initially it results in DNA damage because of multiple things, maybe radiation, chemicals. We all might think that who is getting exposed to radiation here? Nobody is getting exposed to radiation here. Nobody is getting exposed to chemicals here. But we are all getting exposed to radiation and chemicals in a different ways. Like in chemicals, if I give you an example, there is no food currently available without a pesticide, without any sort of fertilizers, artificial fertilizers which are added. And then I'm sure that all of you are aware that in your grandfather's time there was no the incidence of cancer was comparatively lesser than in the current time. So it's not that all the people were dumb in the last year, about 40, 50 years back, and suddenly we all have become smart, and then people are reaching the hospitals. Even Bangalore, if you see, in whole of Karnataka, Bangalore was one of the developed area. And even in Bangalore 30, 40 years before, there were only 2 cancer hospitals which were catering. So, but majority of the people in Bangalore were educated. They could reach the hospital if it's required. But now even there is a cancer hospital in every area. So that is the incidence that has gone up. Yes, definitely pickup rates have gone up. The incidence also has gone up. So we all, as human beings, we have something to do to make for making this to happen. Most probably it is all because of the pollution and the exposure to chemicals that everybody is getting exposed to. So once the causality is there, and then it results in multiple injuries locally, and then tumor starts, and then once the tumor starts, and then it becomes an advanced cancer once it evades the immunity. So tumor initiation, in situ carcinoma, and metastatic dissemination. So initially there will be tumoricidal effect will be there, tumor will be killed by immune system, but over the time immune system will get exhausted, and then it becomes immune tolerance and the cancer grows. So this is how the cancer immunological cycle comes. So it's anything like any adaptive immunity that all of you would have read in microbiology in your second year. So usually whenever there is a cancer, it releases the antigen or it's foreign epitopes, and then these are sort of picked up by the dendritic cells or the macrophages, which acts as an antigen presenting cells, and then these they process the antigens, and then they present to T cells, and then these T cells further activates the downstream immune system like T cells and B cells, and then ultimately T cells getting trafficked into the cancer cells, and then these T cells finding basically find the epitopes on the cancer cell wall, and then they kill the cancer cells by releasing the granzyme or perforins or whatever the different ways. So it's basically you're educating the person to go and kill, but over the time they get tired. The T cells get tired, and then so that's why cancer progresses. So cancer is a great masquerader of everything. I think cancer can camouflage like however it wants. So cancer evades immunity very, very easily. So how it evades immunity? It evades immunity because cancer cells secretes some of the proteins, some of the interleukins, which are heavily immunosuppressive in the environment, and then cancer has the ability to invade into the blood vessel, so which goes to metastasis and then goes to other places, evading local immunity, and then surrounding the cancer, there will be a reaction from the inflammation, which is resulting in sort of a fibroblast membrane or some sort of a membrane, which prevents any of the good cancer tumoricidal T cells getting in and then killing the cancer cells. So ultimately, cancer not only evades immunity by having a layer of protection, also cancer cells automatically downgrades the immune inviters. Like for example, if I have to call you for dinner in our home, I will come and then give you an invitation card so that you can find the location and come. But here what it happens, that invitation card, the cancer cells will keep it inside. It won't show up. So basically the MHCs, that is HLA2, HLA antigens, which should be there on the top of the cells, it will not show up. So it gets evaded from the immune system. So in the same way, there are multiple things. So initially, for few weeks or so, there will be T cells will try to eliminate the cancer, but over the time they learn to live together, and then finally the tumor cells escape the tumoricidal immunity. So there are a host of reasons why it happens. I will not go in depth. I think this is not the right time to discuss all those things. So one of the ways, main 6 ways is, one is evading the apoptosis and self-sufficiency in growth signals. Cancer is one cell which becomes immortal. So basically they can survive even without having any stimulation from outside. And then insensitivity to anti-growth signals. So usually God has given a checkpoints for everything. For example, if the growth is happening more, God will give one checkpoint to stop it. So that stop signals will go away. So resulting in tumor suppressor genes getting away. And tumor invasion and metastasis, and then limitless replicative potential. So they can replicate keep on replicating. There's no stop to them. And then sustained angiogenesis, resulting in going away from the local site and then metastatizing. So there are different ways how we can tackle this. The easiest way starts from giving sort of targeted drugs like rituximab or something, which can go and find the CD20 molecule which is there on the cancer cells like B cells, and then comes the immune checkpoints, and then comes the cancer vaccines to enhance the immunity. So there are many things, but I will go a little bit few of the things in detail. Adoptive T cell therapy, which is my passion. So what is the targeted immuno-oncology approach that we have right now? The first one which came to picture, it was about 20 years before, was the monoclonal antibodies. Monoclonal antibodies are the naturally occurring antibodies which are specifically targeting against single tumor antigen. These works best in patients in whom the tumors express that antigen unequivocally on every cell, and it works best in patients who have got inside the cells are more liquidy, so that the monoclonal antibodies can get inside very easily, and it will work very well in a place where blood can go very easily. These drugs doesn't work very well when there is a barriers like blood-brain barrier or the blood-testis barrier. So inside it may not go well. So one of the classic example of this monoclonal antibodies are rituximab. So rituximab, I think all of you would have used for multiple reasons, maybe for cancer and also for SLE and many other diseases. So all these, basically what does rituximab do? Rituximab will go and catch the cancer cell. Basically they bind to CD20, and then they invite the antigen, different effector cells. So basically they invite the invite complements. So the complements can kill. They invite the macrophages. Macrophages can catch the FC portion. That they can kill the cancer cell, and they can invite sometimes directly B cells, which can kill the cancer cells. So they bind to the surface of the surface receptors. They can't bind inside the surface receptors. These naturally occurring monoclonal antibodies. Next came, see, for this to be effective, you need somebody to come into near to the cell, so that when rituximab binds here, the other cells have to come near to kill that cell, because rituximab per se cannot kill the cells. So direct toxicity is very, very less. So you need a macrophage or a T cell or something coming there, inviting and then getting treated. So naturally these T cells or whatever, they won't get inside very easily, because tumors have an ability to escape from these things. So what has happened now? Now we have a new technology where we have basically two-pronged approach. One side there will be a target, and the other side there will be an invitation for the T cell, invitation card. So that comes like this. So this is the BITE antibody.
When both single-chain variable fragments bind to their target antigens, T-cell activation is triggered, which leads to the release of cytotoxic granules, cytokines, and T-cell proliferation.
So they also invite other T cells. Please come here, so that they release the milieu such that they injure locally.
Or B cell involves membrane perforation followed by programmed cell death induced by enzymes. BITEs trigger serial killing by activated T cells. Approaches to limit adverse neurologic events caused by blinatumomab treatment include the blocking of activated.
So these are the currently available multiple drugs which are there in this area, which is there available now for breast cancer, PSA, prostate cancer, myeloma, many drugs, but many areas. But the most effective drug is blinatumomab, which is there against CD19. CD19 is unequivocally present on the B cells. So this is the exciting era where so many of the new bispecific antibodies have got approved. Blinatumomab in 2014, and then for uveal melanoma, tebenofusp, and then teclistamab, mosunetuzumab, and there are many things, glofitamab. So we in our center, we as a center, we have access to all these drugs very easily, and in fact we were one of the first people to use this drug. It was launched in 2014 in US, and then it came in 2015. We used it in Bangalore. So the next one is, see, now we know that rituximab just goes and binds there. And sometimes T cells may not come when we give bites. So when we give bites is bispecific antibodies, bispecific T cell engagers. Bite is exactly to tell you the full form. Is there any way that we can target, attach some payload to that antibody which can go and kill? Like for example, I have a drone. Drone was all these days, it was just going and dumping something there. But now, not only dumping, I will also add one bomb to it, so that it can go, the moment it dumps, and then it gets blasted, so that it can kill the local area. So this is the way where chemotherapy payloads are attached to the FC region of monoclonal antibodies. And then one of the very nice drug which has come is Adcetris. So this is we use very commonly for patients with Hodgkin's lymphoma. Now a lot of incurable Hodgkin's have become curable.
Adcetris is administered as an intravenous infusion. The ADC travels through the bloodstream and binds to surface receptors of CD30 expressing cells. Non-clinical data suggests that binding Adcetris to CD30 initiates receptor-mediated endocytosis. Vesicles containing Adcetris-bound CD30 are believed to then merge with lysosomes, causing proteolytic degradation of the antibody and the linkers. MMAE is released within the cell. MMAE binds to tubulin and disrupts the microtubule network within the cell, resulting in cell cycle arrest. Cell cycle arrest then induces apoptotic cell death. In vitro data also provide evidence for antibody-dependent cellular phagocytosis, or ADCP.
So the main advantage of this kind of a treatment is that you are not giving a chemotherapy at such strong doses that chemotherapy will damage the other organs. Like MMAE, if you give at right dose, it will cause neurotoxicity. So the off-tumor target is very less. So you don't have to worry about it damaging other areas. So we can now target the right place, right drug, and right way. So these are the exciting area now where so many drugs have been approved, starting from Mylotarg, that is for AML, and then Polivy, that is for B-cell lymphomas. There are many things which have been approved, and then Adcetris, which has been approved for Hodgkin's lymphoma and other CD30 positive T-cell lymphomas. So next one is, normally I think we all are aware that we all have immune system, but our immune system will not kill our own cells. Why doesn't it kill? Because T cells get educated when we are in the womb in the thymus, because thymus will keep exposing all the naturally occurring antigens, and then whenever there is any T cell which is acting against the naturally occurring antigen, it will kill. So basically cellular energy is what we call it as. So it is also not only that God has given additional mechanism. Additional mechanism is, even though there is an active T cell which can kill naturally occurring normal self cell, God would have given something else called as CTLA, and there is a CTLA. So basically this will CTLA and PD1, PDL1. This, if it is there, look, I am self, don't come and kill me. So it is like a marker of self. Like for example, if you are in a combat, all your soldiers would have worn one type of a cap, and then the other soldiers are in a different kind of a cap. So when you try to kill, if your soldier is on the other side, you don't go and shoot him because you have that fellow is holding the same cap. But unfortunately, cancer cells are so smart that they start wearing that cap. So they will tell that, hey, look, low immune system, don't come and kill me because I have the I'm yours, I'm one of yours, so don't kill me. So how do? They do it because of expression of PD1 and PDL1. PDL1 is a ligand and PD1 is a target which is there on the T cell. So even though the cancer cell is expressing antigen and T cells have got ability to go and kill, but T cells will get a signal from the cancer cell saying that, no, I am one of your own, don't kill me. So this is the way how we can escape that is by giving a drug which can inhibit that.
However, cancer cells take advantage of these checkpoints to switch the T cells off and thereby evade immune surveillance. Immune checkpoint inhibitors, such as PD-1 antibody, are drugs that prevent the cancer cells from restraining the activity of T cells by forming a barrier between them. Once the stop signal from cancer cells cannot reach T cells can proceed to attack the cancer cells.
So
T cells receive many different signals from cancer cells. For each, various types of immune
So this is the immune checkpoint inhibitors. So immune checkpoint inhibitors are there now approved for multiple cancers. I'll show you the approvals. So it started with ipilimumab in the melanoma, and then came with pembrolizumab, nivolumab, and now there are so many atezolizumab. There are many things which are available right now. So all these drugs now currently approved for every cancer. If you see, this is the future. This is 2023 approvals. So if you see, all the cancers are approved, majority of the cancers. So my area of specialty is hematology and hemato-oncology. So I look only at Hodgkin's lymphoma, non-Hodgkin's lymphoma, and only a few of my areas. Others, I think I have my colleagues who have more experience in treating other cancers. So the next one came. See, all these things we were trying to utilize the existing T cells, so that the one's own human body T cells, whichever is there, you invite them, or you call them for the dinner, or you call them for, you mark them and then invite them. So all these things we were doing. Is there any way that we can give T cells from outside which can be sort of empowered? Whether T cells directly can it be empowered? So that is one of the way is by doing a chimeric antigen receptor T cell therapy. So we all know that all the T cells gets produced from the hematopoietic stem cells, and then it reaches immature precursor T cells, reaches the thymus, and there where it gets educated, and then finally they become CD4, CD8 cells, and CD8 cells are the one killer cells. They are called as CD8 cytotoxic cells, and CD4 cells are the helper cells and the memory cells which stay back inside the thymus, and then whenever there is a re-exposure to the antigen, they will go and kill. So what we do now we alter this T cell membrane on the receptor, T cell receptor, which is the one which will go and find the target. We alter in such a way that we give them an additional armamentarium. Basically, we make it's like an antibody. We stick that antibody on the T cells. The outside portion will have an exact complementary for the antigen, and then there will be a transmembrane domain which will hold this antibody in the onto the cell wall, and then down we have 2 or 3 additional co-stimulatory domains which will activate downstream pathways. So I will show you how natural immunity works, and then next I will show you how this alteration is going to make a difference. This is a natural immunity.
The T cell receptor assemblies then cluster together.
Whenever there is an antigen, this is the antigen, these are the T cell receptors. And once they bind to the T cell receptors, inside this is what it happens.
Chains form the internal part of the T cell receptor. These chains begin the complex signaling process that activates the killer T cell after receptor binding and clustering. The killer T cell is then ready to attack. Now we can see some cancer cells through a microscope. Cancer cells have changes in their DNA which make them multiply out of control. These changes make cancer cells different than normal cells. So why doesn't our immune system recognize and kill them? Cancer cells can develop many clever ways of hiding from our immune system. One way they do this is to avoid recognition by killer T cells through MHC1 and the T cell receptor. On the left, we see the surface of a cancer cell.
So what we do now is we alter the overall receptors. So we exactly whatever the antigen binding domain we want, complementary domain we find, and then we insert a transmembrane domain. And then how does this happen? All this has happened because of HIV, retrovirus. So retrovirus goes and gets integrated to the DNA. But only the problem with retrovirus is it has got a replication potential. It affects a DNA, and then new HIV is formed, it gets released, and then it goes out and then infects other next cells. But whether is there any way that we can make that HIV replication potential to be cut out? So what we do now is in the HIV DNA, whatever the HIV polymerase is there, that is cut out, so that that virus will not have ability to replicate. But we attached some of the additional sequences, what we want exactly, whole of this sequence starting from here till here, the same sequence onto that virus, so we call it as viral vector, so it becomes a lentiviral vector, and then we put that inside the T cells. And then those T cells will produce those proteins which will go and get stuck onto the surface of the T cells. So there are different generations of chimeric antigen receptors. These are called as chimeric antigen receptors, and there are about 5 generations. I will not go in depth. So how do we do? First is we collect the patient's T cells, that is number 1 on the right side, and then we separate the T lymphocytes, and then we enrich the T lymphocytes. We make them divide very rapidly outside the human body, and then we activate the T lymphocytes, and we add this lentiviral vector, which will go and gets integrated into the DNA, and then it starts producing the exact whatever the complementary that we want, and then which will go and get stuck on the surface of these T cells. And these T cells are then expanded, and then we give these T cells back to the patient, and we give a small chemotherapy to ensure that the natural immunity is cut on a hold, so that these given CAR T cells or chimeric antigen receptor T cells gets an advantage to divide. So this is how chimeric antigen receptor T cells divide and work. These are chimeric antigen receptors.
And are engineered to recognize and attach to a patient's cancer cells via the binding domain. We will now move below the cell surface. The signaling domain inside the cell is similar to that in the naturally occurring killer T cell receptor. Once the CAR T cell is bound, CAR signaling domains begin a chain of events which activates its killer function to destroy cancer cells. A CAR is therefore a modular combination of cell recognition components and signaling components all in one. We are now looking at the magnified surface of a CAR T cell in contact with a cancer cell. Once they are in the body, the CARs can directly bind to specific markers of the patient's cancer cells, shown in yellow, overcoming the need for MHC1 to be present. The bound CARs then cluster together. We will now move below the cell membrane. Here, we are looking inside the CAR T cell at the CAR signaling domains. The binding interaction has activated the signaling domains, beginning a chain of events which activates the CAR T cell. Once activated, the green CAR T cells release toxic chemicals into the cancer cells, which kills them, indicated in red. CAR T cells are known as serial killers because they can kill, release, and move on to kill other cancer cells in a cycle that can occur multiple times. This makes them very effective in the fight against cancer.
So the main advantage of CAR T cell is they have got self-renewing capacity, not the virus. The CAR T cells can divide. So the virus will not, there will be no lentivirus which will go out and infect other cells. The cells can divide, so they basically act as a living drug. So this is the approvals which have happened from last 5 years, starting from Escarta till Carvitic. So there are, mainly it works very well in hematological cancers, so it doesn't work well in solid cancers. So this is the exciting field for us, and then we are going to start trials shortly on for acute lymphoblastic leukemia, DLBCL, and multiple myeloma in our center for with these kind of therapies. So this is the first girl who received CAR T-cell therapy when she was 1 year, so when she was about 3 years, and then she is now, I think she is now 13 years. I've got photo till 10. So this is the first girl who received CAR T-cell therapy in University of Pennsylvania. She was a picture girl on the Time magazine annual basically Innovation of the Year award, and also Barack Obama was there with her celebrating one of her birthdays. So the next one is, this is all these things about oncology, because I am also not, I'm not purely an oncologist. I'm a hemato-oncologist and also a benign diseases also I treat. I treat thalassemia, sickle cell disease, and other diseases. So sickle cell disease and hemophilia, and for example sickle cell disease and thalassemia, they all happen because of the mutation in the beta globin gene. So normally, I think all of us are aware that inside the womb, baby will live properly, right? When even the thalassemic child or a sickle cell child, they will not have any issues inside the womb. What is the reason? Because they don't have a beta globin which is getting synthesized inside the womb. It is only the gamma globin gene which gets synthesized in the womb. So it will be alpha 2, gamma 2, that is HbF will be predominant in the when they are in the fetus, and then when they come out, and then by about 6 months or so, beta globin gene predominates and the gamma globin gene stops. So ultimately resulting in pathogenic beta globin gene dividing and then resulting in symptoms like basically transfusion or the pain crisis or whatever for thalassemia. And now we know why that happens. It happens because of a gene called BCL11. This BCL11 is the culprit which shifts the production of gamma globin to beta globin once the childbirth happens because of exposure to oxygen. It is not a culprit, so it is very much required for normal human beings. But in thalassemic people, maybe knocking off this BCL11 might result in reprogramming of the hematopoietic stem cells to produce gamma globulin, not the beta globulin, so ultimately resulting in cure for the patients. So how it is done? It is done by a mechanism called CRISPR-Cas9. CRISPR-Cas9 is a gene editing tool, like how you do in Microsoft Word. You can copy or you can cut and you can paste. So copy, cut, paste, all the three are possible with CRISPR-Cas9. CRISPR-Cas9 was invented in 1970s. It won 2 Nobel Prize, CRISPR-Cas9. So, but it came to clinical practice only in about last maybe around 7-8 years. And then how it is done, I will show you how naturally CRISPR-Cas9, what work it does, and then how we can exploit it.
Cutting DNA at a specifically targeted location. The technique has already revolutionized gene editing, but scientists are always looking for new possibilities. So what else can CRISPR do? Since being discovered in a bacterial immune system, CRISPR-Cas9 has been adapted into a powerful tool for genomic research. There are 2 components to the system: a DNA cutting protein called Cas9 and an RNA molecule known as the guide RNA. Bound together, they form a complex that can identify and cut specific sections of DNA. First, Cas9 has to locate and bind to a common sequence in the genome called a PAM. Once the PAM is bound, the guide RNA unwinds part of the double helix. The RNA strand is designed to match and bind a particular sequence in DNA. Once it's found the correct sequence, Cas9 can cut the DNA. Its 2 nuclease domains each make a nick, leading to a double-strand break. Although the cell will try to repair this break, the fixing process is error-prone and often inadvertently introduces mutations that disable the gene. This makes CRISPR a great tool for knocking out specific genes. But making double-strand breaks isn't all CRISPR can do. Some researchers are deactivating one or both of Cas9's cutting domains, infusing new enzymes onto the protein. Cas9 can then be used to transport those enzymes to a specific DNA sequence. In one example, Cas9 is fused to an enzyme, a deaminase, which mutates specific DNA bases, eventually replacing cytidine with thymidine. This kind of precise gene editing means you could turn a disease-causing mutation into a healthy version of the gene, or introduce a stop codon to a specific place.
So the same thing is exploited now to edit BCL11 and then ultimately silencing the BCL11. So reprogramming the cells back to gamma globin production, ultimately resulting in cure, operational cure for both thalassemia and sickle cell disease.
Will then be replaced by beta globin, and the composition of the allohemoglobin will now contain two alpha and two beta globin chains. In sickle cell disease, there is a mutation of the gene that codes for the beta globin protein that results in the abnormal hemoglobin expression. Research has consistently shown that removing the suppression by the BCL11E gene on the fetal gamma globin gene can dampen symptoms of sickle cell disease, as it would compensate for the lost beta globin chains caused by that mutation. So what exactly are researchers doing to induce these? Well, in the first step, cells from hematopoietic stem progenitor cells will be isolated from the patient's bone marrow. The Cas9 system will also need to be isolated from the bacteria's streptococcus pyogenes. To help facilitate delivering and precise editing of these cells, the Cas9 system and the guide, also called gRNA, will be delivered as a protein complex called pre-complex ribonucleoprotein. The ribonucleoprotein carrying the Cas9 system will then be infused into the donor cells through electroporation, a method in which the membrane permeability is increased using short time molecules. In step 3, once inside the cells, gRNA will guide the Cas9 internuclease, which is the enzyme that breaks the bond over the DNA together, to the suppressing the gamma globin gene, BCL11 gene. Cas9 internuclease will cut the gene, which induces a repair pathway called non-homologous enzyme. Basically, this pathway will repair the cut by adding or removing nucleotides, which can in turn disrupt the BCL11A gene's function. As a result, this will remove the suppression of the gamma globin gene. Lastly, the gene-edited cells are then infused back into the patient, which will later differentiate into mature blood cells that contain the fully functional BLDE protein. So you must be wondering what the advantages are to using CRISPR.
So this is the beautiful way that we can exploit the naturally occurring systems to do many things. So there is also a lot of work which is going on in cancer care with CRISPR-Cas9. So these are in very, very young stage. I think it will come to clinic in about few years. But whatever that I have presented till now, everything is in the clinic and everything has been available for human use. So this is CRISPR-Cas9 is going to be the future of targeted drug development shortly. And then we can knock off few things, we can add few things, so quite a lot of gene editing is quite possible. So to conclude my talk, definitely cancer department or the overall cancer care, the bench to bedside, it has become very narrow. Previously it used to be 10 years back, whatever they invented, 20 years later it would come back. So totally the lead time was 30 years. Now whatever the invention that happens in the lab in about 5 years before, it will be there today in the clinic. So it's an exciting path in future. The about last century was of a cardiology century. So in fact, I know many of my friends are I have few friends who are CEOs of few of the hospitals. About few years before, when I asked why don't you put a cancer hospital, they would tell no, we'll put cardiac hospital. Who will put Liniac? With one Liniac I can buy 5 cath labs. So no use in buying Liniac. So now people are changing their mindset. I think the future is going to be oncology, and future is going to be preventive medicine, and then future is going to be sort of lifestyle management, which is going to be the future. So I think there are a lot of exciting days for our departments and then all our colleagues, and then this is the right time for the hospital and the college also to consider adding a good oncology unit. There's no point in having an ordinary oncology unit, everybody does it. So it has to be it should start from the patient not getting cancer till patient getting the cancer treatment without side effects. So it's a whole spectrum which needs to be looked at. It is not that we just treat the patient, we are not treating the cancer, we are treating a human being. So we need to treat in a way that we prevent diseases as much as possible, and then whatever the diseases that come up, we should treat in a way that we don't harm or basically we don't bomb them, we target them. Thank you so much, and then I hope it was a visual treat. I'm very sorry for keeping you here before the lunch for long.
Thank you, sir, for a brief overview on targeted immunotherapies. Now I request the chairperson to kindly present certificate of participation to the guest speaker.
Before that, just I want to tell that thank you, sir. Thank you very much for beautifully explaining how cancer cell will cheat us and our own immune cells are used against the cancer cells. Thank you very much, sir.
Thank you, madam.
The chairperson will receive the certificate from Dr. Rajni Kochnur, Assistant Professor of Department of General Medicine.
Instead of myeloma cell, can we fuse that beta cell from the mice directly with the cancer cell, for example, the breast cell, so that what we get a hybridoma that will produce this specific antibody. That is my.
You are telling is it better to infuse hybridoma cells itself into the human body? So, but that will get our own natural immunity will push that out, sir. Will kill it off because it's a foreign cell. So there's a rejection which happens. So naturally, I think all of the human body is trained to see that if anybody non-self comes, kick them off. But cancer has got ability to masquerade that. Yes, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir. We are at the conclusion of this continuing medical education program. We want to extend a heartfelt thank you for attending our event. Your presence and participation helped to make it a memorable and engaging experience.
I am sure all of you in the audience have been enriched or at least stimulated to gain or improve your knowledge of patients with oncological conditions. We value your support and look forward to seeing you all at the future events. We request you all to please join us for lunch. Thank you.